Excellent. Welcome to everyone. Thank you for joining me. Thank you for kicking off the Functional Aging Summit through this pre-con. I hope that you enjoy this course. Pelvic Balance is a course that is going to be really applicable to any of your clients, regardless of their age. Try to think of everything that we speak about in a very broad context on how you can start to weave this into how you already look at your client programming. Now, before we jump into it, just a little bit about housekeeping is, again, if you did not get this PowerPoint, just shoot me a message in the chat box. I will send it to you during our first break. We do have 4.5 hours, so we'll be taking one break in between there. Okay, so stay strong with me. We'll be breaking it just into that one break. If you have any questions at any point, you can type those into the chat box. I'll have my eye on that throughout the entire lecture or session that we are going through. And then if for some reason I don't see it and you really want me to go back and repeat something, then you can, of course, unmute yourself and just kind of say, hey, Dr. Emily, stop and answer this question. And we could absolutely go through that. And then if I show you, I will be showing you some videos. Whatever videos I show you, I will be then sending you a supplemental Dropbox folder that has this additional videos and information for you. Okay, so I do that when I teach virtual courses because sometimes it's hard to grasp a lot of that experience, especially exercises. If I were to show you on Zoom, I'm actually just going to show you some pre-recorded videos, and then I will send you those videos. Okay, and that should be about it. So ask your questions. Try to apply this to your clients and we will have a great session. Okay, so normally pelvic balance, it's actually one of our newest courses through EBFA Global. And if you're not familiar with EBFA Global is an education company that I founded back in 2012. We have the Barefoot Training Specialist certification. We have pelvic balance. We have many, many other supplemental courses through our teachable platform. So do make sure you follow that to continue your journey. And then myself, I speak at a lot of conferences such as Functional Aging Summit. Now, when we think about pelvic balance, and my apologies, and what you can expect with this session is that we're going to be taking everything that EBFA stands for, which is fascial, sensory, integrated, functional movement, timing and coordination. And we're going to be applying that to this concept of the pelvis, pelvic balance. So we are going to be speaking and referencing to fascial lines, fascial perspective. We're going to, of course, incorporate the foot into the pelvis. So foot to core stabilization and how that's affected through various imbalances that we can see within the pelvis. And then, of course, your pelvis connects to your diaphragm. So we have to reference how we breathe and how that influences the pelvis as well. So some of those key topics that you will learn is going to be some of the differences between male and female pelvic anatomy. And this is not just the pelvic floor, but this is also the shape and the structure of our pelvis bones as well. We're also going to look at some common imbalances that you may see in the front of the pelvis, in the back of the pelvis, and then of course this breath, diaphragm, rhythm as well. So when you think about the pelvic floor, the base of our pelvis, I want you to think of this as an extremely functional muscle. It's a postural muscle, and this postural muscle has a baseline tone to it, a baseline fascial tension to it. So tone and tension I use kind of synonymously. And if you ever think about postural muscles, so your slow twitch postural muscles that allow you to resist gravity, you could add in the pelvic floor with that. And a lot of these postural muscles that are slow twitch have a high fascial concentration to them because muscle contractions have an effect on our fascia, and that effect is going to be tension. So I just want you to kind of think about that when you're referencing, you're thinking about the pelvic floor and posture and gravity. So your pelvic floor is an anti-gravity muscle. When we say anti-gravity, because gravity is a force coming downward, when you contract or you put tone into your pelvic floor, you should feel a lift. So if I were just sitting here right now, were to engage my pelvic floor, which I just did, I actually feel like I'm lifting out of my chair, not my sits bones, but the base of my pelvis is lifting. And when you do this, it's actually really interesting. If you do this when standing and you lift your pelvic floor, I actually feel less pressure under my feet. So sometimes we have clients or I'll have patients that are just dead weight in their feet. And they come into my office and they say, I have diffuse foot pain, like my entire foot hurts, right? And I know that typically they have a little bit lower tone or tension to their fascial network, possibly the pelvic floor as well. And they're just subjected to gravity. It is this weight that they just succumb to, where we actually want to oppose it. We want to push into gravity. And that pushing into gravity is directly related to the tone of our pelvic floor. So I want you to understand that as well. And if you're teaching pelvic floor engagements to your client, they should feel and appreciate the lift that is associated with the contraction. Okay. Now there is a rhythm between our feet, our pelvic floor, and our diaphragm. So when I teach foot to core sequencing, if you've taken any of my other courses or BTS, you understand short foot. Now, when I speak about short foot is every time I engage the foot, I coordinate it and sequence it with the pelvic floor. And then every time I speak about the pelvic floor, I coordinate it and sequence it with the diaphragm. So the way that someone is breathing. So we always want to think of our cues to certain exercises or activation sequences is led by or driven by our breath. Okay. Now, there is a requirement for your pelvic floor to relax and then contract. So not everything about pelvic floor programming is about teaching people to get stronger in the pelvic floor, engage the pelvic floor more, connect and contract the pelvic floor. But there is this powerful element of actual relaxation. So can you teach them to let go and kind of disconnect from the pelvic floor? You're not going to have a true disconnect where their, bowels prolapse. It's not going to happen. That's not the way that those muscles contract, right? But can you get a little bit of a relaxation in the pelvic floor so that you can create this sinusoidal relax, contract pattern or wave? Okay. And that's really important when you're thinking about power in a muscle is you have to do the negative to get the positive. Kind of like if I want to jump high, I have to go down before I go up, right? We have to relax before we contract, similar to that. Okay. And then of course, last thing is they're integrated and it's coordinated with your rhythm. So when we are looking at our body posturally against gravity, there's this appreciation, or there should be this appreciation that we were designed to stand up on 2 feet and to be bipedal. So we were designed to walk. Okay. Now, when we stand upright and we walk, that required certain changes in our pelvis. So what's actually interesting is that when you look at the evolution of bipedalism or how we came about to walking on 2 feet, or if you don't believe in evolution, totally fine. You could just say, what is unique about our skeleton that allows us to walk on 2 feet, right? Why is it, or how is it that we are able to walk the way that we walk that is very unique from any other animals that are out there? Let's just look at it that way then, okay? So the changes or the uniqueness of our pelvis and our feet is what allows us to walk. And that's why I'm so focused on or passionate about foot to core sequencing, or the foot and the pelvis, just those 2 areas, structurally, fascially, from a sensory perspective, those are really where the most powerful centers are found, in the core, pelvis, and in our feet. So when we think about the way that we walk, the way that humans walk, we walk in a way that's actually designed to be very efficient. But you got to move in the way that we were designed to move efficiently, right? And that pattern is based around our ability to take long strides. If we do not take long strides when we walk, we start to unravel some of these powerful changes that are in our body or uniquenesses that are in our body that actually allows us to walk efficiently. So we need to take long strides. As soon as we shorten our stride, we start to take away a range of motion from our T-spine and our pelvis. And then that can start to accumulate and restrict things moving forward. Now, taking long strides is part of our unique gait pattern, but also our ability to our ability to anticipate, absorb, and transfer impact forces, or the energy of impact forces, is very unique to our gait pattern as well, and very unique to our pelvis and to our feet. And then finally, we can do all of this with minimal stress to our body. That is the way that we want to be moving. So let's start by taking a look at what is so unique about the human pelvis that allows us to walk the way that we do. Because part of understanding pelvis anatomy is to understand the differences from other animals. So you see our pelvis here on the right. This is going to be the human pelvis, or the Homo sapien pelvis, as far as how it is today. And then if we go all the way to the left, this is going to be a primate's pelvis. And if you think about a primate, they walk typically quadrupedal. So they're on their hands and their knees, right? So they're down on all fours, or on their feet and hands, and they're walking on all fours. Yes, they can stand upright, but when a primate walks, it's very different from the way that we walk. So I'm not saying that we are the only animal that can stand on 2 feet, but the way that we move efficiently on those 2 feet is very unique. So a primate's pelvis, I don't know if you can appreciate, the next slide will show it a little bit more here on the right, but do you see that that pelvis is flat? So the flatness of that pelvis is going to put your glutes directly behind, and it's going to put your glutes in a purely hip extension, sagittal driven plane of motion. Now, primates have very strong glutes. Animals that are quadrupedal, think like a horse, a bull, any animal like that has extremely strong glutes because they have purely hip extension. So if a horse lifts and kicks back, they can generate a lot of power. And it's because of their unique pelvis, or the orientation of their pelvis and the influence that has on their glutes. Now, if you look at the human pelvis to the left, you can see that instead of it being directly anterior posterior, it has rotated out. And now we have this curvature that puts our glutes into the frontal plane. And that orientation into the frontal plane now means that, oh, my leg can AB duct and AD duct. Okay, that's interesting. What does that do when I try to stand on one leg? Oh, well, it allows you, you can see here, my pelvis, it allows you to drop your pelvis and pick up your pelvis, right? So that unique characteristic, not necessarily open chain, but closed chain, frontal plane glute action is what allows us to stand on one leg. So that is very, very unique that we want to appreciate. Now, what you can also see in the human pelvis in relation to the femur is the orientation of the hip joint, the femoral neck, and then look at the angle of the femur. So the femur coming into that valgum, so it's kind of coming into a valgum. You could say it's adducting towards the midline, if that helps you to understand that. That is also purely related to the fact that we are able to stand on one leg, fully stand on one leg. And that just keeps your center of mass in better alignment with your knee and then your foot. If you look at the primate's femur here, straight down, that if the primate were to stand on one leg, they would just totally topple over because of the straight orientation of that femur. So those are some of the initial changes of that pelvis as far as that ilium rotation. You have your femur coming into a valgum. Technically, you also, if you look over here, so this is the issue tuberosity of the primate. This is our issue tuberosity. So you can see it's much larger. And what attaches to the issue tuberosity is, of course, going to be your hamstrings. And your hamstrings play a very important role in how you take long strides and what controls the knee extension of that stride length. So that deceleration of knee extension and the timing of all those muscles is really linked to those hamstrings and the role of hamstrings in gait. So that's another really powerful change as well that we see. Now, if we are looking at male versus female pelvis, there's also some changes there that we'll visit again towards the end, where we're appreciating the sacrum. So this is the sacrum to the coccyx. And if you can see that the male's sacrum and tailbone is actually more tucked under. So it's kind of sitting like this, where the female sacrum and coccyx is like this. Makes sense, right? Because the female pelvis is built around allowing childbirth. So the pelvic outlet, which is here, so the base of the pelvis is the pelvic outlet. That pelvic outlet, you need enough room, so the sacrum and the tailbone have to be pulled back this way. Now, when we speak about tailbone pain and coccydynia, this is important because part of what we need to do with our sacrum when we sit down, and so that we don't put pressure on our tailbone, is you have to have freedom of movement for your tailbone and your sacrum to tuck under. Men's are already tucked under. So coccydynia is actually a much higher prevalence in females than males because of that anatomical orientation of the sacrum and the coccyx. Okay, so that pelvic outlet difference is also really important. Okay, so as already mentioned, our glutes from a gait optimization has taken on this abductory role that allows your pelvis to drop in the frontal plane. And when your pelvis drops in the frontal plane, you trigger, from a sensory perspective, a fascial perspective, you trigger the lateral line to engage, and boop, you pop your hip back up, and now your pelvis is stable, and you continue through the next stride length. So that frontal plane movement is really important. And now another change of the pelvis that is extremely important to optimal gait patterns is lumbar lordosis. So we actually want to have a lordotic curve. As soon as you get that lordotic curve in your lumbar and into your sacrum, you just unlocked your SI joints. And the unlocking of the SI joints now allows your pelvis to nutate and counter nutate. So you can rotate like this. So when we walk, you are actually doing this. So your pelvis is rotating like this. It doesn't go like this. You're doing something different on one side. And technically it kind of goes like this. So you see I'm kind of moving my hands forward and back. So that's also how we take long strides. Your SI joint and the lumbar lordosis is what allows you to do that. Okay. So then that means if you're thinking, let's already take a step back and think about some of our clients. If you have a client that has maybe exaggerated lumbar lordosis, so they have too much of an anterior tilt in the pelvis, they are already in the position that we need to rotate into in order to take long strides. So you can't move anymore into the direction that you were already supposed to be moving, if that makes sense. Because you want to go from neutral to, technically it's your back one that goes anterior, right? Neutral, anterior, neutral, anterior, neutral, anterior, right? So if you're already anterior, I have no choice but to either go more anterior. Now I just compress my lumbar spine, right? Or I choose another mechanism where if I'm walking, I'll just flex at my hips and I'll start to fall forward. Okay. Now, if I have a posterior tilt and I have no lordosis, that I went the other way, I've also locked my pelvis, but to the other extreme, and I'm not able to take long strides because I can't move out of this posterior through neutral and into an anterior. So I'm stuck in this direction. And I know a lot of pelvic alignment issues start to become an issue with age. And if you're stuck in either of those extremes, what it's going to affect, big picture, is the ability for that client to take long strides. As soon as you take away the ability to take long strides, you've just locked the T-spine, and usually you lock the ankle as well. In addition to just locking other access points, is you're not able to fascially load and unload. So think of someone walking, and I'll try to represent this, but try to think of someone walking. And if I'm taking, sorry, this is not going to show much. I'm taking my right leg forward, and you can stand up and do it with me if you want, but I'm taking my right leg forward and then my left arm forward, right? So there's this opposite counter rotation. My right leg is forward and my left arm is forward, right? And then I do the opposite. And if you do this and you kind of exaggerate it, I can feel my obliques, I can feel my glutes on the backside, right? So this rotation that happens with the strides, long strides in the pelvis movement is, you could think of it kind of like wringing out your fascia and then doing this. You're kind of doing this to your fascia, which is keeping it hydrated, but it's also how you move efficiently. So the rotation and counter rotation of the T-spine and the arm swing with the leg coming forward is a way that you can kind of pump fluid into your fascial system. It's how you keep elasticity in your fascia, and it's how you transfer energy so you can move efficiently, so you can walk quickly with these long strides. You start to get your heart rate up, and now you start to get cerebral blood flow, and then you get all this beautiful benefit to the brain, and you protect against dementia and all these other things. And really what that started with was the ability of the client to take a long stride. So if you are into brain health, you've got to be into assessing the way someone walks. I'm sorry, you have to make sure that that client can take a long stride. If they cannot take a long stride and you're doing all of this protective stuff to, you know, increase the BDNF and all of that stuff, you really got to think encompassing of everything. So this walking is really important. Okay, as soon as we take away that long stride, everything locks up. You can't walk fast. You can't get good cerebral blood flow. Okay, so again, essentially this is what I just said. So lumbar lordosis allows us long strides, increased speed, increased efficiency, increased cerebral blood flow. Beautiful, beautiful. We love it. Okay, so now when you are looking to assess your client's pelvis, this is going to involve 3 planes of motion. So if you want to assess the frontal plane, you want to assess the sagittal plane, and you want to assess the transverse plane. So I'm going to take you through what's happening through each of these, and then I'm going to show you a video on how to assess them. So frontal plane, we had already discussed this. You want to have at least 5 degrees in each side so that you can feel the pelvis dropping and hiking up. Remember, the purpose of this drop is that when it drops, you stretch the glutes, you proprioceptively or sensory trigger the lateral line to engage, and they bring that pelvis back up and stabilizes the lateral line. Okay, sorry, real quick question. Gloria had asked, do we worry about heel strike in a long stride? So yes, you absolutely should be doing a heel strike when you take a long stride. When you walk, you should not be doing a midfoot or a forefoot strike. Walking is not synonymous to running patterns. If you believe in doing a midfoot strike for running, which I believe in, comparing running to walking is not comparing apples to apples. Let's say they're kind of different. So when you take a long stride, yes, you should be striking your heel. Okay, good question. All right, so back to it. So we're looking for that pelvis movement in the frontal plane. I'll show you how to do that in a moment. You're then looking for the transverse plane. And that transverse plane, so here's my ilium. My right ilium, if I step forward, and you can stand up, we'll do the assessment again with a video. But if I take my right leg forward, so I'm taking my right leg forward, my right ilium, pelvis, if you just want to think of it, should rotate medially. when I take a right leg forward, my left leg is obviously behind me, and my left pelvis rotated open, or what's called lateral. And then when I switch and I take a left stride forward, my left pelvis opened towards my midline, which is called a medial rotation. My right pelvis, which is the leg behind me, rotated away from my midline and is a lateral rotation. Okay, so the front leg and the back leg are doing something different. Front leg is always rotating medially, back leg is always rotating laterally, and then vice versa. When your left leg steps forward, it's rotating medially, your back leg is rotating laterally. So that's the transverse plane. Okay, and then your rib cage is doing the opposite of that. Okay, so that is where, when your pelvis is moving in the transverse plane, the T-spine is rotating in the transverse plane in the opposite direction. And that's called decoupling. So there's a lot of rotations that are happening in our body and in our spine. Our subtalar joint is doing this, which causes a tibial rotation, which goes up into your femur, which causes the pelvis to do this. And then you're walking, so you do this. And then your T-spine does this because your arms are swinging. And all of that is actually decoupled or canceled out. Okay, that canceling out of all of that movement is so that when all of that gets to your head, your eyes stay level on the horizon. That's the whole point of decoupling, is to cancel out so your head and your vestibular system stay stable. And that your visual, for your visual field and the horizon and your vestibular system are really calibrating or orientating your system in gravity. So if you were to keep throwing off your vestibular system, think of any sort of like vertigo or Meniere's disease and different things like that, they will then have to sit down, they get nausea, they get kind of motion sickness, they lose their orientation, they lose their balance. So things like that is really showing the importance of keeping visual and vestibular stable. Okay, and that's what that decoupling does. Okay, so again, that decoupling is essential for the accuracy of human movement and for energy transfer. Okay, and then finally, your anterior posterior movement in the front or in the sagittal plane is going to be that when your right leg steps forward, the pelvis is actually rotating posterior, and then when your left leg is behind you, it's rotating anterior for you to take a long stride. Okay, so a long stride, if we think of this gentleman taking a long stride with his right leg, the left leg or the back leg has just rotated laterally, anteriorly, and then we have hip extension that's happening. Those three movements are what allow you to take a long stride. So if you have a client that has lost the ability to do true hip extension, whether it's a range of motion or a strength issue. So let's say maybe the glutes are weak, so they can't do a true hip extension, right? That's going to compromise stride length. If they're stuck in a posterior tilt, they're stuck in an anterior tilt and they can't move into an anterior range of motion, that's going to restrict their stride length. And then if someone can't open laterally that pelvis, or medially on the other side, so they lose that transverse plane. So those are really where you want to make sure you're optimizing the range of motion. And then of course the person's got to swing the arms, right? So if let's say habitually someone doesn't swing their arms, it's going to compromise their stride length. Okay, and this decoupling that we're referencing. So I'm going to pull up a video to show you this. So let me see real quick. And again, I will be sending you all of these videos that we are going through so that you can have this. Okay. Okay.
Next, necessary for optimizing gait, and having optimal pelvic mobility is necessary for optimizing gait and bipedalism. This means that we want to understand how to assess the pelvis in all three planes. I'm going to take you through the frontal plane, transverse, and sagittal. If you remember that with every step that we take, your pelvis must essentially be unlocked and have this optimal rotation or movement in each of the planes. We're going to start with the frontal plane, which is going to be the abduction side of the pelvis. Now, in an open chain, we think of pelvis/hip abduction as more the leg that is moving away from the body. Here, because it's closed chain, we're going to be thinking of how the pelvis would actually drop or hike up. So a pelvic drop or a hike, oftentimes people will think of a Trendelenburg. We need to have at least 5 degrees of a drop in the pelvis to trigger the glutes to engage and stabilize us to stand on one leg. Okay, so the assessment technique for this to do either on yourself or of course on your clients is it is going to be called the cha-cha. You're going to have your feet together and your hands are going to be on your pelvis. So I want you to find the ASIS, which is the front of the iliac crest. With your hands on the ASIS, right now I have my fingers on the ASIS, I'm going to bend my right knee. So when I bend my right knee, I felt my pelvis drop. So when my pelvis on my, essentially this is my swing leg picked up and my pelvis dropped to the side of my swing leg. The pelvis, which is my left, when it dropped down, is now stretching my glutes to trigger them to engage and then pull the hip in to stabilize for a single leg stance. Okay, so again, I'm on both feet, my hands are on the ASIS, and I'm bending my right knee. Bend my right knee and my pelvis dropped. Great, that means I have frontal plane mobility on my right side. I go back to our start position, and then I'm going to do the same thing on the other side. My left side, when I bend the knee, it dropped, so that's great. That was triggering the glutes on my right side to engage to stabilize in a single leg stance. Now, the way that I like to do this with a client is I like to keep repeating. I shut my eyes a lot when I assess, but I would bend the right knee and then straight. So just stay on the right side and find the rhythm of the right pelvis dropping down. So dropping down, right? Get it, feel it, appreciate it. Other side, it's dropping, it comes up. It drops, it comes up. So I have optimal mobility in this pattern. Now, if I were to alternate like I was walking, I should feel, and I'm going to shut my eyes to appreciate it, that I'm dropping to the right and then to the left. So I actually feel, this is why it's called the cha-cha, right? I feel that my pelvis drops for each one. Now, in a client that maybe one side drops and then the other gets sticky, they often present with low back pain, maybe SI joint pain, different types of spinal restrictions. It could be from a long flight, it could be from being seated too long, but this is definitely going to start to talk to them. So this frontal plane assessment is going to be the first key aspect that you want to assess. The second plane that we are assessing is going to be the transverse plane. Now, if you remember from the lectures that when I step with my right leg is coming forward to take a step. My right pelvis rotates what's called medial. It's rotating inward. And then of course my back one is rotating out. But we're focused on how this is rotating inward when I take that step, which means that as I'm going from a swing position, remember this, right? But now this is rotating forward and my pelvis should be rotating this way. Okay, so we're going to stay in the same cha-cha position. And now when I bend my right knee, I should feel that not only does my pelvis drop, but it wants to go like this. Okay, I'm of course exaggerating that, but the right pelvis goes forward and then back. Forward and back. Do you see how I'm rotating towards the midline with my pelvis? That's what I should be feeling in my client. And then of course the same thing this way. When my left knee bends, it should be rotating this way. I'm exaggerating it, right? If I'm here in this position, I bend my left knee. Did it rotate inward? Yes, I felt it rotate inward, right? Okay, it rotated in, perfect. It rotated in, okay? So that's saying that, okay, Dr. Emily has optimal frontal plane and she's getting medial rotation. Every time she bends the knee, she feels that medial rotation. Okay, remember that that is necessary in order for us to take long steps, long strides. Okay, the final assessment that we're going to do is the sagittal plane. This is looking to see if the client is in an anterior tilt or a posterior tilt. I like to use the rib cage for that position. So the rib cage, oftentimes when someone is in an anterior tilt, you'll notice that they get rib cage flaring. So the rib cage flaring, because the rib cage has such a strong relationship with the pelvis, that's starting to create this association with an anterior tilt. So by feeling and cueing and building awareness of rib cage to pelvis relationships helps you to find that neutral position for the pelvis. Remember, we do not want to be overly anterior because we need to go from neutral to anterior to take a long step. That's what your back leg is doing. And then if we're to posterior, it essentially locks your pelvis and is really difficult to take optimal stride length. So finding neutral for your pelvis. As a quick recap, frontal plane, 5 degrees in the cha-cha, getting that drop in the hip when you bend the knee. When you bend the knee from the transverse plane, this is where you get the medial rotation. The medial rotation allows that swing leg to come forward. And then finally, the anterior or posterior position in the sagittal plane. I do that through the rib cage. This is allowing your pelvis to move to take long strides. Next, we're going to be going into how to assess the T-spine and then how to optimize mobilization to both the pelvis and the T-spine.
Great. Okay. So that is going to be your mobility assessment. So you are looking at what is the potential of my client to be moving in frontal, transverse, sagittal. What is their potential, right? That's the purpose of assessments, is what is the potential. If you see a limitation anywhere, you understand the impact of that limitation. So now let me take this one step further. Because there's such a powerful connection between the pelvis and the T-spine, when you're thinking about how this applies to gait, to walking, to movement, to speed, to get cerebral blood flow so we can protect the brain, is you also then want to be thinking about the T-spine. Anytime you assess the pelvis, you have to assess the T-spine and vice versa, okay? And like I said before, I would technically add in the ankle joint as well. Okay, so let's do our T-spine assessment.
However, there's a deep integration behind T-spine mobility, pelvic mobility, and ankle mobility. So if you are looking to get optimal pelvic mobilization in your client, it really is in your best interest to be assessing the T-spine and the ankle in those same clients. I'm going to take you through 3 of my favorite T-spine mobilization assessment techniques, and then these are also your exercises to increase T-spine mobility. The first one that I'm going to take you through is based off of SFMA. For this one, you're going to bring your feet together. The hands can be by your side, and you're going to rotate over your shoulder and look behind you as far as you can. Both shoulders are going to rotate, and you can rotate all the way down towards your feet and ankles. So I'm rotating as far as I can over my right shoulder, and then I'm coming back to the center. And then I often have clients do it again. So you're rotating all the way, and then we're rotating back. Now, what you're looking for is that as your client rotates, can they get their shoulders in line? If you could go even further than that, that's great. But to get into a lying position, that's going to be our target goal, okay? If I do the other side and I rotate over my left shoulder, and now I have my head turning as well, bring to the center, one more time. I rotate all the way over my left shoulder, and I just want to see that the shoulders are in line. Oftentimes I'll ask a client or patient, how does one feel versus the other? Do you feel some restriction? And then they can also explain and communicate how each feels subjectively during that assessment. The second assessment that we're going to do is going to be on a chair. And if you wanted to have something that's across like a dowel or something that you're following, you absolutely could do that. For this, you're going to be on a chair, and you just want something that's going to lock the knees, lock the pelvis. So I'm on the edge of the chair. I imagine this is something like a yoga block. My feet are down, and I am in a position like this. So this locks the pelvis, which makes this true T-spine mobility. Now, when I'm rotating, and I rotate with my head and eyes following, I'm not going even further, but when I rotate like this, I'm doing a comparison of my right side, and then I'm rotating to the left side, and I'm seeing how much rotation I have. Now, what you're looking for is that if you were looking straight down, you would like to see someone rotating at least a 45-degree angle, but you also want to make sure that there's a 1-to-1 ratio between these. So what I rotate on the right, I want that similar to what I'm rotating on the left. Then please remember that I said that each of these assessments is actually your exercise as well that could be used to increase T-spine mobility. Okay, so this is the second one. Your third and final assessment is going to be on the floor. Now, you don't have to do all 3 assessments with every client or patient, because this last one that I'm demonstrating, not everyone will be able to get onto the floor and into that position, but I'm going to show it to you anyway. So we're going to come down. I'm in a kind of a child's pose position where I'm on the top of my feet. Now I need to have my elbow between my knees because it's actually locking my pelvis, just like this one locked the pelvis. My elbow goes in between the knees to lock the pelvis, and then my hand goes on top, and I start in a position like this. From here, I'm going to rotate open as wide as I can, and then I'm going to come right back down. And we could do a couple of assessments on each side. And then we're coming up and then rotating back down. Okay, and then we repeat the same thing on the other side as well. Same position. I want to have my elbow in between the knee. This is going to lock the pelvis. My hand goes on top and I start down, and then I'm going to rotate open. And then I come right back down. Okay, remember this is also a mobilization exercise. And then I'm coming down. What you're looking for in this one, similar to the seated position, is that you want to see symmetry between each of these. Whatever I'm doing on the right side should match what I'm doing on the left side. Symmetry of the T-spine is actually more important than this optimal range of motion. If you at least have a symmetrical range of motion on both sides, then that's going to translate down to the pelvis of a symmetrical unlocking of the pelvis, which translates to a symmetrical stride length when they're walking. And that's really where we start to see some of this impact, or where it can start to fall apart and cause compensation for the clients. Coming up next, I'm going to take you through my favorite pelvis and T-spine mobilization exercise.
Okay.
So I know that this is a pelvic balance. So I know that this is a pelvic balance core.
Okay, so from assessing the T-spine, we then want to understand, how do you bring mobility back to these different areas? How do you mobilize the pelvis? How do you mobilize the T-spine? And then how do you mobilize the pelvis and the T-spine in conjunction? So those are going to be the next 3 steps of how you would look at programming and how you want to kind of flow through this. So I'm going to take you first through the pelvic mobilization, some T-spine mobilizations, and then, like I said, some combined.
I'm going to take you through 3 of my favorite pelvic mobilization exercises that I like to have my clients and patients do first thing in the morning. These are very gentle on the body. It's actually based off of what's called somatics. So it's going to seem like I'm not doing a lot of movements, that maybe this isn't quite effective, but it's just reinforcing the subtlety of the pattern of the pelvis that is mimicking gait. So again, I'm going to take you through 3. They're very subtle, so try to reflect inward and just focus on how the pelvis could potentially be moving while walking. Let's go onto our back. And we're going to start in a position that your knees are bent and your feet are flat on the floor. So these are called pelvic rocks. So we're going to start in a neutral pelvis. To find your neutral pelvis, you want to stack your rib cage with your pelvis. So this is stacked. My hands are going to be on my hips so I can feel the pelvis rotating, or theoretically you could have your hands down by the side. Now I'm going to start by going into a posterior tilt. Go from neutral to posterior. Build that awareness into the mind and into the proprioceptive system. Again, posterior tilt, and then relax back to neutral. Make sure the ribcage and pelvis is stacked. Posterior tilt, and then back to neutral. Posterior tilt, and then back to neutral. Let's do one more. Posterior tilt, and then back to neutral. Great. Now we're going to go into the anterior tilt. So we're going from neutral position, and then I'm going into an anterior tilt. So I'm thinking of taking the bowl, and I'm spilling forward, and then I go right back to neutral. Anterior tilt, and then back to neutral. Anterior, and then neutral. Perfect. Now we want to combine them. So we're going to go from a posterior tilt. I feel my lower back on the floor, and I'm going to go all the way through neutral, and I'm going to exaggerate the anterior tilt. I'm going to go to a posterior tilt, and then I'm going to exaggerate the anterior tilt. Posterior tilt, and then exaggerate the anterior tilt. Again, this is just, think of this as a proprioceptive reset, or you're connecting mind-body awareness. If you want to coordinate the breath, you could use this as the exhale, and then this is the inhale, this is the exhale, and then this is the inhale, okay? The second exercise is going to be with your legs straight and your hands are by your side. Again, as much as you can, you want to stack the rib cage and the pelvis. Depending on your pelvic position and muscle tightness, you may or may not be able to go truly neutral. But for the sake of this, we'll just say that this is fine. Now, what we're doing is we're going to imagine or mimic that we're walking. So my right leg, I'm pulling my right hip down. So my right leg, like someone's pulling my right leg out of my body, and then I'm bringing it right back. And then my left side, someone's pulling my left leg out of the socket. And then I go right leg, and then I go left leg. And this is just, all I'm doing is walking. I'm trying to keep my rib cage and pelvis stacked as much as I can as I'm walking. So my right leg, and then my left leg. And this is all reinforcing the frontal plane movement of the pelvis. Think of this more as the stretch, and then a stretch, and then a stretch, okay? Now your third and final that is similar to this, but now we're actually going to intentionally engage muscles. So now instead of thinking of this as a stretch on my right side, I'm actually engaging my left side. I'm engaging my right side. I'm engaging my left side. And then I'm engaging my right side. So kind of bringing the QL and the obliques together. And then the left side together, pelvis rib cage, pelvis rib cage. So one is a stretch, the other is more of an activation. So as a recap of what we did is we moved the pelvis anterior posterior in the sagittal plane, and then we were stretching and mimicking walking in the frontal plane that was opening up between the rib cage and the pelvis. And then the third and final is that we were engaging between the rib cage and the pelvis, getting the QL and the obliques, building that awareness through pelvic mobility. These exercises.
Okay, perfect. And I love those. Those are some that I don't know if anyone happens to work with any hypermobile or Ehlers-Danlos clients, but those are really good, gentle mobilizations for someone with Ehlers-Danlos or hypermobility, because they move almost too much into the range of motion and they have a lot of muscle pain, that this is a really good way to just kind of say hello to these different areas. You can think of them almost like undulations. So when you do undulations, you are then allowing a relaxation of the nervous system to kind of let go some of that hypertonicity of muscles. So I really like those. They're also not in gravity, so that's also why they're gentle. So now we're going into the T-spine.
Because T-spine mobility is so important to the way that people walk and it unlocks the pelvis, I'm going to take you through a series of some of my favorite T-spine mobilization exercises. And I actually use this as a sequence or series that I give to my patients or clients to do on a regular basis. So I'm going to have you start by finding a quadruped position. In that quadruped position, I'm going to have you start by having your toes tucked under. Your head is in line with the spine, and your shoulders are directly over your wrist. Now we're going to go into a standard cat-cow, but I'm going to be cueing your feet as well. So I'm going to have you start by tucking your pelvis under, round your upper back, and bring your chin to your chest. And then you're going to go to the opposite, but you're going to bring the tops of the feet down, arch the lower back, and bring your chin up and drive your sternum forward. And then go back into the opposite movement, tuck your toes under, push through the pelvis, push through the rib cage, and then let's go back into the other direction. Tops of the feet go down, drive through the sternum, and let's do one more. Tuck in the toes, tuck the pelvis, chin to chest, push between the shoulder blades, and one last time. Tops of the feet go down, arch the lower back, and drive through the sternum. Beautiful. Find your neutral back. And now what I want you to do is you're going to sit back slightly, extend your left arm forward, almost as if it's at 12 o'clock. Take your right arm and you're going to go underneath your left armpit. And then you're going to reach your left hand forward and look at your right hand. This is going to open up the rib cage. Now, if you want to add a little bit more challenge, your left arm can come straight up, and this will drive a little bit more rotation through the T-spine. If you would like, you can bring your left arm back down to 12 o'clock, walk your fingers forward, and then relax into your right shoulder. When you're ready, come out of that, bring your right hand to 12 o'clock, take your left arm and go underneath your right armpit. Relax down, looking at your left thumb. You may bring the right arm up if you would like. And then when you're ready, bring the right arm back down, walk the fingers forward, and then bring your hand back to 12 o'clock. Sit all the way back onto your heels as much as you can, and let's take both hands, and we're going to walk them to the right. When you bring your left arm forward, I want you to put it on top of your right hand, and then you're going to spin and look underneath your right armpit. So we should feel this into our lats. And then good, you're going to come back to the center. And then when we do the other side, you're going to lead with your left arm. Take the right hand and you're going to put it on top of the left hand. And then you're going to spin through and look underneath your left armpit. Again, you should feel this into your left lats. And then good, let's walk back center. One more in this child pose position. You're going to take your right arm, you're going to reach it straight out to the side, and then you're going to drop your shoulder down, and you're going to look out to the left. And then good, let's repeat on the other side. So take your left arm, you're going to reach out, drop your left shoulder. And then we find our center. Your arms are going straight out in front, and we're going into a standard downward facing dog. So you want to curl your toes under, and you're going to drop your heels and push back. Now, to get a little bit more into your T-spine, instead of focusing down on your heels, I want you to drive in between your rib cage. So I'm driving my chest in between my shoulders to open up my rib cage. I can come forward, and then let's repeat that. Go back into your down dog, start to bend your knees, and then drive your chest in between your shoulders. And then good, come to your knees, and you're going to walk your hands back to your knees. Your toes are tucked, and I want you to push back into a yogi squat. So we're in a position like this. Now in the Yogi Squat, I want you to turn your feet out. You may remember that we had referenced that this is a great pelvic floor stretch. This is a pelvic outlet stretch, which is great, but now we're combining it with the T-spine mobilization. I'm going to take my left hand and go into my left leg. My right arm is going to go straight up, and I'm going to look at my hand. I'm then going to bring my right hand down, bring it into my right leg, and then I'm going to bring my left arm up. And then good. Let's repeat one more on each side. So left arm goes down, hold the left leg, and then right arm comes up, and then right arm comes down. One last time to the left. Keep your left leg, keep your chest open, and then we're going to look up to the left hand, and then we come down for one more. Your left hand is going to go down. Your right leg is going to go in between your left arm and your left leg. So we're going to rotate forward here. I'm going to bring my left leg over the right, and I'm going to rotate and face the left wall. Trying to keep the sternum up. And then we'll rotate back to the center, and then we'll just switch sides with our legs. So my right leg goes over the left, my left arm goes over the right knee. I'm keeping my sternum up, and I'm rotating towards the right. And then I'm relaxing back to the center. So this was an easy sequence of T-spine mobilization that, again, I like to give to my patients and clients to do on a daily basis. It could be something that is done before they train, or it could be done first thing in the morning.
Great. So the final one is that we're going to combine this, and that combination is going to be the pelvis and the T-spine together in a great release technique.
This next series is going to combine T-spine mobilization with pelvic mobilization at the same time. This series is inspired by the Gray Institute that looks at triplanar motion. What I'm going to do is have you start by bringing your right leg forward and your left leg back so you are in a lunge position. You're going to slightly tuck the pelvis under, and then you're going to keep the chest up. Now I want you to keep the hips squared, keep the pelvis as it is, and then we're going to start to shift our body forward. So you could think of this like a pelvic rock or a shift, or almost like a pulse that is shifting forward, but I'm keeping my pelvis as is. I'm going to do this 10 times. On the 10th one, I'm going to hold it forward. I'm going to bring my arms over the head, and now I'm going to start to lift my sternum. So I'm not doing this out of the lower back, my sternum, and I'm going to pulse 10 times forward this way, still keeping my pelvis as it is. On number 10, I want you to hold, and now you're going to take your arms and you're going to go in the frontal plane like you're painting a rainbow. So I'm rotating in the frontal plane, keeping my pelvis in that tucked position, and then keeping my rib cage open. I'm doing this 10 times. After the 10th time, you're going to bring your arms down into a position like this, and we are going to rotate in the transverse plane, still keeping the pelvis forward, still keeping that back heel down. So we're doing this 10 times, and then we're going to repeat the same thing on the other side. So let's bring our left leg forward. I will rotate this way, left leg forward, right leg back, tuck the pelvis under, shift forward, and then I'm going to pulse 10 times. Perfect. And then number 10, again, your arms go straight up, and then we're going to pulse 10. Perfect. Make sure you're not taking it out of your lumbar. You're leading with that sternum. Number 10, you're going to hold, and then we go into the frontal plane, opening up between the rib cage and the pelvis. We're doing this 10 times. And then on the 10th one, you're going to bring your arms down, keep your hips where they are, and you're going to rotate in the transverse plane. Great. After you do 10 repetitions of each of those, you could either progress this to make it a little bit more challenging, that progression could be that the leg that is behind, you're actually going to rotate it inward a little bit, and then that shifting forward is going to hit more of the psoas. Please be careful with the knee. Or if you had a chair or a bench, you would put your foot on top of the chair or the bench, and then that's going to get a little bit more into the hip flexors and open up the pelvis and rib cage. This is another one of my favorite mobilization exercises that I have my patients and clients do on a regular basis. Again, whether that's first thing in the morning or before training.
All right, excellent. So does anyone have any questions on that part of this? Okay, so just kind of recapping, that first concept that we covered is that we are establishing and appreciating the pelvis, not necessarily the pelvic floor, but your pelvic girdle, the skeletal structure, and how that connects to the importance of optimal movement, meaning bipedalism or walking, right? Stride lengths, arm swing, pelvis, T-spine, rotation, decoupling, and how that requires triplanar motion of the pelvis, how we assess that, and how we can start to bring mobilization to that tissue. You, of course, don't want to stop there. After you mobilize the pelvis and the T-spine, you then need to bring in a layer of activation to then stabilize that new mobility that you just introduced to the pelvis and the T-spine. But this would be your first layer, okay? Next layer that we would go into is, of course, going to be the actual pelvic floor muscular anatomy, the fascial anatomy, and then how we can mobilize that as well. Okay, so someone asked Activate Fitness, what about foam rolling beforehand? Absolutely, you could do that. So this was just showing some of the gentle actual mobilization techniques. So typically in EBFA and all of our programming, we do inhibition, mobilization, activation, integration. So just kind of think that down or write that down if you want. Inhibit, mobilize, activate, integrate. What I showed you was that mobilization, that step 2. So the inhibition, which could be the foam rolling, the body tissue work, the trigger point release, you could absolutely do that as well. And those muscles that you would be inhibiting, I actually go into that when we do our anterior pelvis imbalances that we see, but that would be partly, you know, I can't tell you exactly which muscle to release every single time in your clients. Typically, they're the global muscles though. So is it the TFL? Is it the ruc fem? Is it the QL? Is it the piriformis? Which muscle is preventing that optimal triplanar motion of the pelvis, and then the associated T-spine mobility. So you got your step 1 first. That's the inhibition. We'll talk about that a little bit more in a few moments, but the mobilization slides, that's what I just showed. That's your step 2. And then you, of course, have to follow it with a activation, which is going to be the diaphragm and the pelvic floor. Okay. Elderly client with osteoporosis modifications. So great question. That is where I would look at maybe some of, look at all of the mobilization techniques that I went through, take a step back and see which ones work with your clients based off of their balance, stabilization, their mobility. Do they have arthritis? Can they get on the floor? Can they not get on the floor? Right? And then we modify there. Every assessment that I showed is also technically a mobilization exercise. So if you're locking the pelvis and then just rotating to assess, technically this is also a mobilization technique. If they have arthritis and osteoporosis and a fall risk, then you could do it seated, just like I showed. Don't do the one on the floor, right? That's not going to be possible for those clients, but that's fine. I just want you to know that that's an option. Maybe we are doing the T-spine, or sorry, the pelvic mobilization where they're just standing up. They could hold on to something and do the pelvis rock forward. Maybe they don't have to do this. That's a lot of balance that's involved, right? No problem, right? So try to modify in the way that you can, knowing that I've shown you a repertoire of exercises, and then you piecemeal the ones that work for your clients. Okay, because that is always a part of the reality. Okay, really good questions. Any others? Okay. Woo. If you need to, you know, run to the restroom or grab some coffee or whatnot, please do. Otherwise, I will continue because we will be taking just that one break. Okay. And we'll take that one break in approximately an hour. So I'm going to continue going through to the ligament and the muscular anatomy. If there are any additional questions, just please type those in. Otherwise, we are going to continue. Okay, so we did the mobilization. That was just the skeletal structures themselves. Now let's just get an appreciation for the ligaments of our pelvis, and then of course the muscles. So when we look here, this is going to be your inguinal ligament. Your sacrotuberous ligament is actually back here. So if you can see my arrow, I'll show you another orientation as well, but you have your sacrotuberous ligament here. Underneath that, you'll have your sacrospinous ligament that's actually coming here. You have your obturator membrane here. These are all of your ligaments and the joint capsule that would stabilize your hip joint. Here's your pubic symphysis that has a little bit of movement like this. That allows nutation and counter nutation is your pubic symphysis as well. If we look from the posterior perspective, we can appreciate the sacrotuberous ligament here. So this broad one that my arrow is showing, please remember that because we're going to release that in a little bit. Underneath that is going to be your sacrospinous ligament. Those are two really important pelvic ligaments that you want to understand. What actually runs between your sacrospinous ligament and your sacrotuberous ligament is your pudendal nerve. So if you've ever heard of the pudendal nerve or a pudendal nerve entrapment, that is when you can get an adherence, a stickiness, or like a kink in the hose on the pudendal nerve. Sometimes that can be from pelvic floor adhesions, too much engagement of the pelvic floor. It's going to be the posterior pelvic floor that's responsible for that. I've had patients actually get a pudendal nerve entrapment because they were engaging their pelvic floor way too aggressively and doing Kegels really incorrectly. They were just like maximum contraction hold on versus having their breath coordinated with it and kind of find this ebb and flow. And we start to appreciate the muscle anatomy of our pelvic floor. Just real quick, we have an anterior pelvic floor, we have a posterior pelvic floor. We actually have 3 layers to our pelvic floor. You could think of your pelvic floor from local muscles and global muscles. Local muscles are going to be contracting first, or you want them to contract first. They're more of your stabilizers, where global muscles are more mobilizers. So I want you to start to appreciate here how this says obturator internus. It's a little fuzzy, I do apologize. So obturator internus down here, blending into this broad muscle here, iliococcygeus. Now in BTS level 1 and some of our other courses, we speak a lot about hip joint centration. Hip joint centration, really important. We'll be briefly covering it here as well, so don't worry. But hip joint centration is really built around your deep rotators engaging fast enough to stabilize the femoral head. Your deep rotators, one of those muscles is the obturator internus. And I want to emphasize that your obturator internus actually myofascially blends into your pelvic floor, into your iliococcygeus, which is part of your posterior pelvic floor or part of your levator ani. That blending is really important. Here is your piriformis. This is actually a global muscle. It's not a local stabilizer. We'll go into that even more. It can be a little instigator muscle that if that piriformis is overactive, it can kind of lock down the sacrum and your coccyx or your tailbone. And then it makes it very difficult for your pelvis to nutate, counter nutate, for your pelvic outlet to mobilize. So you really do want to assess and understand the piriformis and finding balance in that muscle for an optimal pelvic balance. Slightly different perspective. This is looking inferior to superior. Here we can appreciate that same thing. Let's see here, obturator internus right here. Do you see that? Right here we go. It's a deep rotator coming this way, wrapping back into blending into this broad muscle, your iliococcygeus. Do you see how your iliococcygeus inserts onto your tailbone? So that balance is going to be really, really important. So you can have someone who has a hip labral tear or poor hip joint centration who also complains about tailbone pain or coccydynia. And this is often why. Is because of that blending and that imbalance of that blending. Here's a piriformis coming around again, associated with the deep rotators, but not part of your deep rotators. It's a global muscle. Coccygeus, pubococcygeus, iliococcygeus, those three are part of your levator ani. Now, when we are looking at the pelvic floor, we just want to appreciate initially that there are layers, deep layers, superficial layers, the deepest layers. You can think of that almost like your pelvic diaphragm, and it's actually the part of the pelvic floor that is actually myofascially connected to your diaphragm, which is your posterior pelvic floor. So the deepest layers of your pelvic floor are your posterior pelvic floor. The part of the pelvic floor that myofascially blends into your feet is the posterior pelvic floor. Part of the pelvic floor that blends into your diaphragm, again, it is the posterior pelvic floor. So that is my go-to to find balance in that levator ani and those three muscles of the levator ani. Here again, just briefly showing it, you have your first layer, superficial, second, anterior pelvic floor here. Third, deepest is the posterior pelvic floor. You can see the orientation of the glutes here coming this way. Okay, again, just appreciating it. Same thing here, levator ani, just another orientation for you to see that. Here we go. This is your tailbone. We'll be doing a release in a moment that is going to run from your ischial tuberosity, which is this, to your tailbone, which is right here. And this is where you're actually working along. Kind of like right here. This whole light green area is what we're releasing. And what is also directly under that and in association with that is your sacrotuberous ligament. So a lot of times people can have iliococcygeus adhesions or stickiness, whatever words you want to use, but they also have that stickiness and adhesions in the sacrotuberous ligament. So doing a release to those muscles can be very beneficial to individuals who have kind of a locked pelvis, who have piriformis syndrome, who have sciatica, who have a hip labral tear. So we do want to always understand that and appreciate that. Anne asked, is levator ani a muscle group? Yes. So the levator ani is a group of muscles. It's not one muscle that is lifting your anus, hence the name levator ani, right? It is going to be these muscles in conjunction. I have another slide here. So pubic, puborectalis, iliococcygeus, pubococcygeus, them as a group of muscles is going to, and I apologize, these images are interchanged. This should read pubo and this should read ilio. My apologies. So these should be switched. Okay, but these three muscles together are your levator ani. Okay, great question to understand that and appreciate that. Okay. Your anterior pelvic floor had already mentioned that, and then your superficial layer. Okay, just kind of briefly going through these. Some of the comparison, the male superficial layers slightly different in orientation. Obviously, there's different anatomy, right? But the orientation of the muscle fibers is slightly different in the female versus male orientation. You can see there's more of an oblique nature of the superficial fibers here. Women's is more transverse. So a pelvic floor release to the anterior pelvic floor. A great way that you can do this for men is that if you take a foam roller and kind of like one of those long traditional foam rollers, if you have a traditional roller from Trigger Point, the orange ones or the black ones, and you set it on the floor and you sit on top of it, sitting on top of it and then leaning forward for men is a great way to do an anterior pelvic floor release. Doesn't work in women. It's actually painful in women. So you can try it and, tell me if you agree. But if you shift forward for a male and then you just kind of rock from the right side to the left side, you're releasing a lot of these soft tissue structures in these muscles. So it can be quite beneficial for men as well. Okay, pelvic floor, already mentioned this, that this is an anti-gravity muscle with an anterior, a posterior. It's a group of muscle that is then further broken down into three layers, superficial to deep. We know it's fascially integrated with the diaphragm, the pelvic floor, with our feet. Okay, now this is briefly going into some of those additional fascial interconnections just to build a deeper appreciation. Your anterior pelvic floor, the front of your pelvic floor, myofascially blends into your transverse abdominals, your TVA. So if we think of the base of our pelvis coming forward, we're blending into our TVA. Posteriorly, we're blending into the deep sacral fibers of our glute max. Laterally, we're blending into your obturator internus of your deep hip rotators. Superiorly, we're blending into our diaphragm, and technically the anterior pelvic floor, your psoas that is sitting in front, blends back into your pelvic floor. So there's this broad spider web of fascial attachments coming from the pelvic floor, making this a very integrated muscle, which is why I absolutely love the pelvis, the pelvic floor, and building and programming with the pelvic floor into every single one of my patient programming, because it's that deeply connected. Okay, so what we want to do is find a rhythm of this myofascial connection with the diaphragm and lead that with our breath. So the breath is the driver to these pelvic rhythms that we're looking for. And if you think of it with our diaphragm, that when we inhale, take a deep inhalation, your diaphragm is going to be moving down, right? And then when we exhale, your diaphragm is going to be lifting up. When we engage the pelvic floor, if you were thinking of it engaging your core during an exercise, right? We would be doing that on the exhalation. So if I'm doing a squat, or you want to be, if you're not, you want to be, okay? So if I'm doing a squat, let me just try an example. If I'm here, and again, I stand up, and I'm sorry that you can't see that much, and I never wear the appropriate clothes for Zoom images, but let's say I'm doing a squat. I'm doing a squat, and then if I were to come out of the squat, that's obviously where I want to engage my core, right? I'm not letting it go and prolapsing as I go down, because I'm still engaging, because now I have more pressure on my system, right? But where there's an uptick or a upregulation of the pelvic floor is going to be on the positive phase, right? And that's where I'm going to exhale. So the positive phase of a squat is where I exhale. That's where I get higher engagement TVA pelvic floor. So the lift of the pelvic floor is going to match the lift of the diaphragm or the exhale. Okay. And then if I think back about my feet, and if you've taken anything with me before and you understand short foot, if I was doing my squat again, right? So I'm here, I'm down on the bottom of my squat. I'm going to push my toes down when I'm pushing up, right? And when I push my toes down, the arch of my foot lifts. So if we think of this all kind of integrated, that I push my toes down, arch lift, pelvic floor lift, exhale, diaphragm lift. So I'm actually coming up. The positive phase of my squat, I am stacking my domes. I'm lifting my arch, my pelvic floor, my diaphragm, and then technically the pellet. All of those domes are stacking for stability. In yoga, they refer to these as bandhas. So you are lifting the bandhas, or you're stacking the bandhas, whichever word you want to use, which means that if we are finding a rhythm, I would kind of want you to think about inhalation, diaphragm down, inhalation, relax the pelvic floor. It's not letting go completely, but it's relaxing. There's a drop. And then the exhalation is going to lift the pelvic floor, lift the diaphragm. Inhale, diaphragm drops, relax pelvic floor, exhale, lift pelvic floor, diaphragm lift, right? So we got this kind of ebb and flow that we want to find. A lot of people get really wrapped around engage, 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 but we need to relax the pelvic floor as well, okay? So now I'm going to show you how I introduce pelvic floor identification, let's say. We will do a release of the pelvic floor. So just note that the order is, I just want you to go through the experience, and then I will tell you the order in which we would do those, okay? Similar to how the question was asked earlier, well, can't you foam roll before you do some of these pelvic and T-spine mobilization? 100%, 100%. right? So just I'm pulling a snapshot out, and then we're going to build the program once we understand those snapshots, okay? So the first one, to appreciate the pelvic floor, not the programming part of it, the pelvic floor. How do we identify? I'm going to show you 2 ways that I teach pelvic floor identification. And then from there, we'll build in the diaphragm and the breathing with it. We, of course, incorporate our feet with it. And then we take a step back and say, well, what happens if someone has too much engagement? How do we inhibit, mobilize, and then go to this activation state? Okay. So I'm going to just pull this back for a moment. And then I'm going to show you 2 ways that I like to activate the pelvic floor. You can please do this with me on the video. I'm still here. I'm totally doing it with you. You just can't see. And then let's go. Okay. First one is going to be standing. Second one is going to be on my back, on your back. All righty. And I like to show both because sometimes clients connect with one wording more than the other. So that's why I like to do both.
One of the best ways to build pelvic floor appreciation is to go through an activation or a coordination exercise for the pelvic floor. Now, if you remember, the pelvic floor is a muscle that contracts together in this anti-gravity movement that has a lift to it. Yes, it can be divided into an anterior pelvic floor, a posterior pelvic floor, and technically a right and a left. But please do remember that we are trying to emphasize the integrated action of the pelvic floor. If you may remember that the anterior pelvic floor is myofascially blended with your transverse abdominals. This means that when we engage the anterior pelvic floor muscles, I want you to feel like you can engage somewhere within the TVA, or even if there's like a proprioceptive stimulation into the TVA. And then the posterior pelvic floor myofascially blends into the deep sacral fibers of your glutes. This means that when you engage the posterior pelvic floor, you may feel an activation or a proprioceptive extension into your glutes. It'll be the deep glutes, not the superficial glutes. I'm going to take you through 2 ways that I build pelvic floor awareness. It's a little bit of a coordination exercise, and then we can use these to integrate pelvic floor strengthening in the programming I will also be showing you. For the first one, we're going to do it standing. So for the standing exercise, I want you to start with your feet shoulder width apart. Start by having your rib cage directly over your pelvis. So you could think of this as a cylinder and your pelvis as a cylinder. You want to have them stacked. Your next step is you want to have soft knees and just feel nice and connected through your feet. Starting this exercise, we're going to begin with the anterior pelvic floor. We're going to isolate out your anterior pelvic floor, which is done through a Kegel type exercise. Now, this is not the way that you should always be engaging your pelvic floor. It's an awareness exercise. For the Kegel, you could think of this as stopping the flow of pee or stopping the urination. So that engagement, which is a Kegel, is the anterior pelvic tilt or the anterior pelvic floor engagement. It's going to be at approximately 20 to 25% of your max contraction. So here we go. Knees are soft, ribcage, pelvis stacked, and then we're going to start with the anterior pelvic floor. Now, as I engage, I feel a little bit of a radiation towards my TVA, and then I relax, and then I engage again. It's a little bit of a lift, and then I release. And then again, I'm engaging. I feel it 20, 25% is radiating here. And then I release. You're doing this at your own pace. You could just think of it as almost like a heartbeat or a rhythm. There's a lift and then a release. There's a lift and then a release. Beautiful. I now want you to relax the anterior pelvic floor, and we're going to go into the posterior pelvic floor. Stay exactly as you are with the knees soft. Relax the anterior pelvic floor. And now we're going to get into the posterior. To engage the posterior, you're going to imagine stopping your poo or lifting the levator ani, which is technically the muscle that we're engaging. So here we go. Same position. I'm going to lift my levator ani, and then I'm going to release. I'm going to lift the levator ani, and then release. Every time I do it, I feel it radiating into my deep glutes. My glutes aren't contracting, but I feel it radiate, and then release. One more, engage, and release. Beautiful. Again, awareness exercises, okay? Now let's start to bring a coordination into this awareness, which means I'm going to have you engage the anterior pelvic floor, hold it, engage the posterior pelvic floor, hold it, and then we'll release both. Here we go. Engage the front, engage the back, release both. Engage the front, engage the back, release. So lift, lift, release. Lift, lift, release. If it's too much because you're looking at me, shut your eyes if you need to. Lift, lift, release. Lift, lift, release. Can you engage both the front and the back at the exact same time? So there's a lift, release, lift, release, lift, release, lift, release. Now, every time you lift your pelvic floor, I want you to just start pushing your toes into the floor. Toes down, release, toes down, release, toes down, release, and it feels like you almost want to exhale. Every time you push your toes down and you lift your pelvic floor, I want you to exhale. Exhale, release. Exhale, release. Exhale, release. Do you feel how that's coordinated? Yes, we are building foot, core, breath connections, which is a huge part of pelvic floor awareness. The second one that I'm going to show you is going to be on the floor. And this one, we're going to imagine that the base of your pelvis is like a clock. I'm going to show you standing, and then we're going to go onto the floor. Okay, so the clock is going to be here. The base of the pelvis is the clock. Your pubic symphysis is 12 o'clock. Your tailbone is 6 o'clock. And then your right ASIS is 3 o'clock. Left ASIS is 9 o'clock. So 12, 6, 3, 9, that's your clock. The face of the clock is going to be at the base of your pelvis. I'm then going to cue you to draw 6 o'clock to 12 o'clock. And then I will cue you to draw 3 o'clock to 9 o'clock. When you do those engagements, 6, 12, 3, 9, I want you to connect to the tension in the base of your pelvis. 6 to 12 is the pelvic floor. 3 to 9 is actually your TBA. Here we go. So you're going to bring it down onto the floor. And I'm going to have you in a position that your knees are bent and your feet are flat on the floor. Start by taking your rib cage and you're going to tuck it down so that your rib cage and your pelvis are stacked. Your feet are flat on the floor. And you're going to take your hands and bring them just inside your ASIS. This is where you're going to feel that you're engaging your pelvic floor. Your eyes are going to be shut so you can visualize. And let's start by finding our clock. So your 12 o'clock is your pubic symphysis. Your tailbone is 6 o'clock. Right ASIS is 3. Left ASIS is 9. Let's take an inhale through our nose. And as you exhale, start to draw 6 o'clock to 12 o'clock. Just nice and gentle, 20%. Draw 6 to 12, 6 to 12. Keep exhaling. And then I want you to release. Inhale through your nose. Again, start to exhale. 6, 12. Keep exhaling. Do you feel underneath your fingertips? Do you feel that tension as you're doing this? And then release. Inhale through your nose. We're going to add on. Start to exhale. 6, 12. Hold. And now draw 3 to 9, like 2 bookends. 3 to 9, 3 to 9. Keep exhaling. And then good. Release. Let everything go. Inhale through your nose. Let's do one more. Start to exhale. 6, 12. Hold. 3, 9. Keep exhaling. Feel the tension. 6 to 12. 3 to 9. Tension in the base. Tension underneath your fingers. Beautiful. And then good. Release. Inhale through your nose. Beautiful. I want to add one more bonus onto this, one more bonus. On this next one, when you do it, as you do 6, 12, 3, 9, please try to push your toes into the floor. Just see if they want to connect. Here we go. Start to exhale. 6, 12, 3, 9. Feel the tension. Keep exhaling. Now see if your toes want to connect. Just push the tips of your toes into the floor while holding 6, 12, 3, 9 and exhaling. Do you feel that connection? And then good, beautiful. Release everything. Inhale through your nose. And we're going to sit up when you're ready. So these are 2 pelvic floor awareness exercises that I like to build pelvic floor appreciation. Some of them are based off of coordination. Can your client identify anterior versus posterior? And then can your client appreciate how you add layers of tension? And then of course, add the feet and your breath into it, and you're getting a full integrated pelvic floor activation.
Excellent. So those are 2 ways that I like to bring pelvic floor awareness. So again, the awareness is either an exercise of connecting, feeling, identifying the pelvic floor, but it can also be the true activation itself. So in our sequence of a reset that we'll be going into, think of this also as an activation, or is it just an exercise that you are doing as part of the rest of your program to build a strong pelvic floor, excuse me, could be any of those or actually all of those. Now for the diaphragmatic breathing, you would be integrating this into the way that you are doing the pelvic floor awareness. So you want to inhale as you're relaxing the pelvic floor, and then as you go through the clock, or as you lift the front and the back, stop the pee, stop the poo, lift the pelvic floor, you would be exhaling as you do that. So that's how you start to integrate the diaphragmatic breathing. If you are not familiar with diaphragmatic breathing, I will show a brief video on that, as well as end range expiration. So the 3-dimensional breathing that is powerful to relax the pelvic floor is going to be the first part. And then why I like end range expiration so much is because that in itself can be a pelvic floor activation exercise. And I will go into end range expiration as well. So again, please join me if you are familiar with diaphragmatic breathing. It's a great way to just calm your nervous system and get you in a good pattern for the rest of this course.
One of the most important connections to appreciate when it comes to pelvic floor function is the diaphragm and pelvic floor. Because of that, if your diaphragm is not functioning the right way, your pelvic floor cannot function the right way. So we're going to take a moment to focus on diaphragmatic breathing and how you can use this exercise and these cues to increase the optimization of diaphragm function in your clients. We're going to be referring to this as 3-dimensional breathing, which means that not only are we focusing breathing into the belly, but we also want to make sure that we're feeling the rib cage expand and that we're feeling the base of the pelvis release. So those 3 dimensions is giving the expansion and the relaxation / activation to these deep core local muscles. For this, I'm going to have you bring it onto your back and we'll get started. So you are in a position that is on your back, your knees are going to be bent, and your feet are flat on the floor. Now, you, of course, could do this in different positions, such as on your stomach, in a quadruped, seated, and even standing. But for the sake of this video, I'm going to have you on your back. We're going to start as your step 1 is taking your rib cage and pelvis, and you're going to stack them, which means you may need to tuck the pelvis under slightly. We're going to start by bringing one hand on the sternum and one hand on the abdomen. Now for this,
I just want to also briefly add that if you are familiar with diaphragmatic breathing, or you're just like, this is belly breathing, it's not that complicated. Just try to still listen and see if maybe there's one slightly different cue that you pick up from the exercise.
I want you to focus your inhale and your exhale through the nose. When we do our inhale, I want you to start and just see which hand is moving more. And then exhale, just nice and relaxed at your own pace. Again, inhale And exhale. Now, if you were with your client, you would want to see which hand is moving more. If the hand that is on the sternum is moving more, they're using a supradiaphragmatic breathing pattern. And we want to cue them to emphasize being below the diaphragm. So you want them to direct all of their breath and energy into the base of their pelvis or the base of their abdomen. Now, if you wanted and you were in person, you could place your hand on top of their hand. And as they inhale into the belly, you're giving them just a little bit of resistance, thinking like a pound or two on the hand. You're never fully pushing down. That is also a form of resisted diaphragmatic breathing. So now your first position again, let's inhale and feel your belly rise. And then as you exhale, the belly is going to come in. Now, the second dimension is going to be the rib cage. So you're going to take your hands and you're going to put them on either side of your rib cage. You could even put a yoga belt around the rib cage, and that helps to give that awareness of rib cage expansion. Same thing, belly's still going to rise. Inhale when you're ready. And exhale, the belly comes in and your rib cage starts to come in. Again, inhale. And exhale. So big inhales. As you inhale, I want you to feel that your rib cage expanding laterally and posteriorly into the floor. Your third and final dimension is going to be the base of the pelvis. So the bigger the inhale, you want to feel the belly rising. You want to feel the rib cage expanding. And then you want to feel like you're filling up so much that you have to breathe into the base of your pelvis. And there's a relaxation or a slight pressure down into the base of your pelvis. So when you're ready, hands can be as you wish, wherever you feel comfortable. And then here we go. Let's do a big inhale. And then exhale. Again, inhale, belly rise. Keep exhaling, rib cage expand. Keep exhaling into the base of the pelvis. And then release. Great. Diaphragmatic breathing is something that I love to do at the start of the session. One, it connects the client to the breath, but it also connects them to the pelvic floor and to the local stabilizers. Doing just a couple minutes of that diaphragmatic breathing helps to get them into a great nervous system set position and connects to the body.
Okay, great. So then I'm going to go through end range expiration, which this is, again, how you would be tying it to the pelvic floor activation that we had just done. And then just real quick, Suzanne asked, pelvis is not moving. That is correct. So when you are doing, I don't know if that question was during the breathing or during the clock, but I'm going to answer it for both. So when you do a pelvic floor activation or awareness, whether you're standing or you're on your back, your pelvis does not move. So the way that you would be able to know that the client is engaging the pelvic floor the right way. So let's say we're standing, right? Again, not the best outfit, I apologize. But when I'm engaging the pelvic floor, I'm not doing I'm not doing that, I'm not doing this, right? I'm engaging the pelvic floor, and you have absolutely no idea by just looking at me because nothing is moving. Same thing when we diaphragmatic breathe, is that there's the inhalation and the exhalation. The rib cage and the pelvis are stacked, but there's no anterior or posterior tilt or movement in the pelvis. Now, the million-dollar question is, well, how do I know that they're engaging their pelvic floor the right way, right? That's a quite intimate muscle to try to palpate to see if they're engaging it. So the way that you do it is if you put your hand just inside the ASIS, and I believe I said this on the video, but just inside the ASIS, you're going to have your tissue just right there. I'm doing it on both sides. And then I'm going to engage my pelvic floor. Did you feel that tension underneath your fingers as soon as you did that? Right? You should. that is the way that you can identify that on your clients without being in any, personal space. This is also how you can identify when they're doing end range expiration and breathing diaphragmatically the right way, is you'll put your fingers just inside their ASIS during the breathing exercise as well, and you will feel that same tension as well. Okay, so no pelvic movement, tension just inside the ASIS, and this is what you'd want. So Suzanne says, when supine, the 12-6 has a cue, but what is the cue for 3-9? Or does it feel the same in the TBA? So you would be drawing 12-6, that's the pelvic floor, right? So they're coming together. And then the 3-9 is going to be like two bookends sliding together here. So that's technically your TBA. So 12-6, I just felt some engagement, but then when I go 3-9, boom, I really feel it underneath my fingers and my ASIS. So again, relax, 12-6, I feel engagement, boom, 3-9, I just upticked my TBA and I felt more. So that would be the cue, whether you're seated, you're standing, you're on your back, whatever it is, that's how we want to be thinking about it, okay? And that's why I do step 1, 12-6, step 2, 3-9, step 4, lift a foot, push your toes down, whatever the successive cue is, but I do step, 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 okay? Good job. Okay, so here we're going into the end range expiration.
Once you understand diaphragmatic breathing, you can start to use breathing techniques as a pelvic floor activation. We're going to be taking a look at end range expiration and how you can use an elongation of the exhalation to actually activate the pelvic floor. We're going to start by doing a 4-second in, followed by a 4-second out exhalation. And then we're going to increase that to 5 seconds in, 5 seconds out. And then to start to get into the end range expiration, we want to start to double the exhalation of the inhalation that comes in, which means we're going to do 4 seconds in, 8 seconds out, and then finally we'll do 5 seconds in, 10 seconds out. So I'm going to take you through those 4 levels. Now, as you're doing end range expiration and you're exhaling, especially the 8, 9, 10 seconds, I want you to feel how you have to get into your deep core to do that. I want you to actually go back to the pelvic floor exercises that you're familiar with. And as you're exhaling, think of the clock. Think about lifting the pelvic floor. And if you even want to add in connecting your toes to the ground, now we're getting a full foot to core integrated sequence that is driven by the breath. Let's get into that same position on your back with your knees bent and your feet flat on the floor. Now your hand position could be where you are comfortable. Start with your rib cage and your pelvis stacked. Again, hands could be here. I'm going to have my hands on my pelvis, but you go where you feel comfortable. I'm going to shut my eyes, and we're going to keep the inhale and exhale to the nose. When you're ready, I want you to start to inhale 4 seconds through your nose. And then as you exhale 4 seconds, feel the belly start to fall. Again, inhale through the nose. Now we have 5 seconds in. And then start to exhale 5 seconds out. Feel the belly coming in. Rib cage comes in. 4, 5. Now we go to 4 seconds in. Inhale 4 seconds. And then exhale 8 seconds. 2, 3, 4, 5, 6, 7, 8. Inhale 5 seconds. When you're ready, inhale 1. And exhale 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Inhale. We'll do one more. And again, exhale 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. Perfect. So I hope that you were able to feel that as you do an elongation of your breath, that your pelvic floor naturally wanted to engage. And then as you did that pelvic floor engagement, did it feel like your toes naturally wanted to connect to the ground? I like to use end range expiration for the clients or patients that are having a very difficult time engaging the pelvic floor. If you explain the clock to them or the anterior posterior Kegel exercise, and they're just not getting it and not connecting to it, this is a great way to help them activate the pelvic floor without really giving a pelvic floor specific cue.
Yeah, absolutely. So, again, the end range expiration where you had inhaled for 4 seconds, exhaled for 8, and then that elongation, that's really where you're trying to coordinate the clock, how they can push their toes into the ground. That's really starting to bring the integration element about what we're looking for. So we went over pelvic floor identification, standing on the back. We did the diaphragmatic breathing, the end range expiration. You obviously want to be integrating those. So you inhale and then you exhale and go through the clock of the pelvic floor. You inhale, you go through the pelvic floor awareness. You start to push your toes into the ground. You inhale and you start doing that rhythmically. Now, there was a question that I did want to answer that Active Age Fitness had, and it said, would there ever be a time that you would push out the belly? And that is such a good question. Okay, so the point of why we are doing a pelvic floor engagement, like the hierarching purpose of why we engage the deep core muscles before we lift something heavy, before we lean over, whatever it is that we are engaging the core to obviously protect the spine. And the way that we do that outside of just tension, fascial tension, is through pressure. So intra-abdominal pressure, that is really what we're measuring. So if I wanted to measure how much you're engaging your core, I really wouldn't be doing an EMG on the deep core muscles, one that's very difficult to do, but what I would be measuring is intra-abdominal pressure. And the greater the engagement and the greater the integrated engagement, the higher the intra-abdominal pressure. Okay, so now there's 2 ways that you can increase pressure in your abdominal compartment. The first way is to lift the pelvic floor, engage the TVA, get the multifidi. So I'm doing an isometric tensional-based engagement. Increases pressure, right? You can feel pressure, right? Engage your pelvic floor and then push. Yes, I feel pressure in my container, right? The other way that you can increase pressure is that you could push your stomach out. And if you want to kind of do it with me and you push your stomach out, technically, I also increased pressure. But the efficiency and stabilization of one mechanism is not the same as the other mechanism. When we do the pushing out mechanism, that is a unstable position. You've just destabilized the anterior pubic joint, the groin, the psoas, the adductors, the abdominal aponeurosis, structures that we're going to go into soon. And as soon as you push out, boom, you destabilize them. So you really do not ever want to push the stomach out. Now, people will do this because they don't have sufficient endurance or strength or awareness to have it be more tensional based. It's not drawing in, it's tensional based. It's not sucking the belly button to the spine. Again, different technique, it's lower. It's sitting between your ASIS, which is where that cue should be. Now, if you've ever seen, obviously, weight belts. Now, weight belts, the purpose of a weight belt is that it's increasing the pressure because it's kind of like a super, super tight belt, almost like a compression sleeve for your calf, is it's increasing the compartment pressure. But what happens is that to increase the pressure even more is that what people do is they'll push their stomach into the belt, which is why being dependent on weight belts is very kind of damaging in a sense as far as strategies. Is if you learn to push out against the belt, technically your pressure goes higher. It's the only way you can increase your pressure. with a belt on, you wouldn't pull away from the belt because then the belt isn't doing what it's supposed to be doing, right? But the same thing, you don't want your clients to push out. If you give them a more challenging exercise and you kind of push them past the point of their strength, people's compensation mechanism is they push out. So do be very mindful of that you should not be doing that. Okay. Here's just a breakdown that you'll see in the PowerPoint for the standing cue, for the laying on the back cue. Now, and then of course the diaphragmatic breathing that we had gone into. Okay. Now, the important part, or this kind of a side comment, situation could be if someone has overactivation of the pelvic floor. Maybe they have a pudendal nerve entrapment, they have piriformis syndrome, they have a hip labrum tear. We don't want to just push them into activate, strengthen, engage the pelvic floor, because we need to, again, always find that balance of relaxation and activation. So there is a time and a place to go back to our inhibit, mobilize, activate, integrate, that series. And there's a time where we have to do that inhibition step 1. Okay, not always, but there are certain situations such as what I had explained. That step 1, that inhibition blending into step 2, which is the mobilization of the pelvic outlet, is important for some of our clients. And then we move into the activate or the awareness, which is what we did. Okay, so what I now want to take you to, which will be the last part before we take a break, is going to be the inhibition of the pelvic floor, the piriformis, a pelvic outlet stretch, and a piriformis stretch. Really, I would actually change the order. So I do apologize. I would do SMR to the pelvic floor, or inhibit pelvic floor, inhibit piriformis, move the piriformis stretch up under here, or just mobilize piriformis, and then pelvic outlet stretch 1, pelvic outlet stretch 2. Okay, so I'm going to take you through that right now. Now, when you're doing the release of the pelvic floor and the sacrotuberous ligament, we're going to use something like a lacrosse ball. I have the Naboso Neuro ball, which you could absolutely use, but something that's about this size. So if you have one, then definitely go get it. If you need a second while I'm pulling up the video, run and get your lacrosse ball. Okay, perfect. Okay. And I love this one. I love this release. It's very, very powerful. Yes, here. Okay, and now this is called posterior pelvis reset. So it is going to be applicable to those with coccydynia or tailbone pain. So that's really one of the first things that comes to mind when I do pelvic floor, piriformis, pelvic outlet mobilization, but it's also some of the other reasons that I had said. So hip labrum, SI joint, low back pain, locked pelvis, anything in the anterior. So it is very broad. I just want you to know that that's why it's filed under the posterior.
The following is a reset for posterior pelvic pain. This is effective for anyone who may have sacrotuberous ligament pain, pelvic outlet syndrome, or potentially coccydynia or tailbone pain. This series will involve inhibition, mobilization, followed by activation. The first part of this series is going to be the inhibition. What we are targeting here is the inhibition of the sacrotuberous ligament, followed by an inhibition of the iliococcygeus or the levator ani muscle.
Okay, so those are together. Remember the anatomy, that the iliococcygeus is very broad and the sacrotuberous ligament is essentially running kind of in parallel or deep to that muscle.
For this release technique, you will need a lacrosse ball. Now, I do not recommend using a tennis ball as the compressibility is too high. You also want to be mindful of the size of the ball. The smaller the ball, the less effective release that you will feel. You want to do this in a seated position in a chair. Typically, a harder chair is better because it provides resistance against the ball. We're going to start by releasing the right side. So since you are in a seated position, it's easy to find your ischial tuberosity or your sits bone. So I want you to palpate and find your sits bone on your right side. After you have found your ischial tuberosity, I want you to take the ball and you're going to go directly on the ischial tuberosity, and then you're going to go just inside the ischial tuberosity. So now I'm on my pelvic floor, I'm on the inside. And then from here, I'm just going to sit nice and relaxed. Inhales and exhales. If you wanted to increase the amount of resistance while you are in this position, what I want you to do is you can lift your leg up and then slowly lower your leg down. Similar when we did our other myofascial release techniques, that you're moving the limb to increase the pressure. After we're in this position for approximately 30 seconds, I want you to roll your body forward and to the right. So we're going to be working in a diagonal. If we think of this as our ischial tuberosity, this is going to be our tailbone. So you want to make sure that you are moving the ball in that diagonal pattern to effectively get the structures of iliococcygeus and sacrotuberous ligament. If I move just horizontal, I'm going to miss that ligament. So make sure that when you shift your body to the right, you're actually shifting to the right and forward. So then I'm in the new position. I'm hanging out here. Again, if I want to increase pressure, I just lift my leg up and lower it. I can do that a few times. And then after I'm in this position for approximately 30 seconds, I'm going to go one more time. I'm going to go up and over, and now I'm very close to the tailbone. Make sure you're not on the tailbone. Nice and relaxed in this position. And then again, of course, we could lift the leg up if we would like. We're hitting 3 spots per side. I'm releasing the right side, and then we want to do the exact same thing to the left side. You're going to start by finding the ischial tuberosity. The lacrosse ball goes just inside the ischial tuberosity. So I'm hugging the inside edge of the bone. I'm staying here. Of course, you can lift the leg if you would like, or you can stand nice and relaxed. Deep inhales. After 30 seconds, you go up and over. So now we hit another spot within the sacrotuberous ligament. Lifting the knee if we need. 30 seconds here. And then finally, we go to the third, where we're closer to the tailbone. Now, you may feel that one side is more sensitive than the other. That's completely normal. Let's say maybe you have a torn hip labrum or piriformis syndrome or other pathology on one side, but not the other. You might feel a lot more sensitivity on one side. And again, that's completely normal. We just focus the release on that side. So I do another 30 seconds in this final side. And after I do both sides, sacrotuberous ligament release, I am now ready to proceed into the next step, which is going to be releasing the piriformis. The next step in the posterior pelvic release is going to be mobilizing and inhibiting the piriformis. For this, we're going to use the same lacrosse ball that we used for the sacrotuberous ligament. And we're going to do approximately a 1-minute release per side, followed by a mobilization. We're going to bring it down onto the floor, and I'm going to have you find your right side piriformis. So we're going to start by placing the ball in like the pocket of the glute. So where the pocket of your jeans would be, we're going to tuck the ball underneath the hip, and then we're just going to angle our body a little bit towards the ball to increase the pressure onto the piriformis. We're going to stay in this position. If you want to increase the pressure to the piriformis, again, drop your knee out to the side with a few rocks, staying in position 1 for approximately 30 seconds. After 30 seconds, I'm going to have you roll a little bit more to the outside. So I just moved my body to the left, the ball rolled to the right, staying here. And then again, I could do small rocks with my knee. Depending on your time, you could do approximately 1 minute to 1.5 minutes per side. After I do the right side, I'm going to do the exact same thing on the left side. I'm going to find the pocket of my glute and then lean my body towards the piriformis. And then I'm going to gently rock my knee out, or I could stay nice and relaxed if I would like. 30 seconds in spot one. And then after 30 seconds, I roll my body to the right. The ball moves to the left. And then I do a few of the leg abductions to increase that release. Let's say I'm here for approximately a minute, minute and a half total. And now I'm ready to go into the mobilization of the piriformis. Now there's some strong research supporting the association between tight piriformis or overactivation of the piriformis and coccydynia. So for the mobilization of our piriformis, we're going to go into a 90-90 position. Now, if this is not friendly on your knees, you could do this in a seated position or on your back so that you can control how much stress you're placing on the knee. You're going to start, I have my right knee forward and I'm in a 90-90. I'm going to rotate my upper body, so I'm facing my front knee. I'm going to walk myself forward, but as I walk forward, I have to keep my glute on the floor. So I'm coming forward here and I feel this definitely into my piriformis. And then if I'm going from this position, let's say I can walk all the way out and I start to drop my stomach towards my thigh, but I keep my sternum up and I'm keeping my glute on the floor. 30 seconds here. I like to walk up and then we're going to switch to the other side, 90-90 on the other side. We're going to rotate towards the front leg, walk, walk, walk. Keep your hips down on the floor. Keep your chest up. Again, if you have the flexibility, you're coming down. So this is kind of like a modified pigeon or pigeon variation. And then we come all the way up, and I like to do 2 rounds on each side. So we're going to go to the first side again. In this position, rotate towards the upper body. You're walking down. Keep the hips on the floor. Keep the glutes on the floor. Lower down if you can, but please keep the glutes on the floor.
Remember, these are options. So if your client has arthritis, they can't get down on the floor, not a problem. These are options. If you stretch your clients, you can always have them on the table and do a figure 4 stretch. You can bring the leg across the body. So there's other ones that are a little bit friendlier for some clients based off of their age, arthritis, range of motion. Okay, so just again, we see these as options. It's more the series and the flow that I want you to appreciate.
Progress into our pelvic outlet stretches. So we've been through a sacrotuberous ligament release, a piriformis release, a piriformis mobilization. Now it's time to start opening up the pelvic outlet. You could think of this as a pelvic floor stretch. I'm very loosely using that word because really you're starting to bring a little bit of a stretch or an opening to the pelvic outlet and the base of the pelvis. The first pelvic outlet mobilization is going to start in a quadruped position. So I'm going to be on my hands and knees. For the sake of this, I'm going to have the tops of my feet down. And what I'm doing, it's a very subtle movement. I'm keeping my back flat. I'm going to shift my weight back. Now, as I shift my weight back, what is happening is that my sits bones are spreading. So I shift my body weight back and I actually feel my sits bones becoming wider. And then if I shift forward, I should feel my sits bones coming in. Let's do a couple repetitions of that to see that you can feel that. Keep the back flat and the pelvis slightly tucked. So I'm shifting back and then I'm shifting forward. And again, shift back.
So please note that I'm actually slightly tucking my pelvis under or my sacrum. So if I were to sit in this position and just kind of hang out for a minute, let's say, same thing with your client, whether they're on a stretch table and they're just on a quadruped on the stretch table, or they're on the floor and they're okay getting onto the floor that way, then you're shifting back and I'm guiding my sacrum to tuck under. If you were with your client, you could actually put your hand on the sacrum as they're sitting in this position and guide it to move into a posterior position. And then they just hold there and they completely relax the pelvic floor as much as they can. And they should feel a stretch in the base of the pelvic outlet. If they have coccydynia or tailbone pain, they may feel a little bit of a pulling on the tailbone. That's totally fine, but it's just creating that mobilization. I'm loosely saying stretch here.
Right? Can you feel, or could you visualize, if you shut your eyes, can you feel like there is an opening and then a coming together? Okay. Now, this is passive. I recommend doing this weight shift back and then hanging out in that posterior position. You want to be in an approximately 45 degrees of a weight shift back. You're not going all the way back into a child pose. It's just a weight shift back, hanging out. If you are in a gym setting or a public setting, I actually like to have the client facing a wall so that they could be in this position and they can just kind of hang out and relax and let go. When you shift posterior, you need to really let go the pelvic floor and really just imagining the whole base of the pelvis relaxing and opening up. That can be quite vulnerable for some people, which is why I always recommend that their backside is facing the wall out of respect for them. As you shift back, you can hold each one 30 seconds and do approximately 5 repetitions. After you do this first pelvic outlet stretch, we would progress to the second pelvic outlet stretch, which is going to be a yogi squat or like a frog squat. So for this, you're going to start and you can flow from one to the next. You do your weight shift back, and then you're going to shift forward. You're going to tuck your toes, walk your hands back, and then you're going to push yourself back into a yogi squat. Now, a yogi squat, which is this position, is a relaxed position of your pelvis. Your pelvis is actually letting go and relaxing. You have to relax it also. So make sure that when you're in this squat that you're not holding on, you're letting go. Again, if this is something that you're in a public setting and it makes people uncomfortable, be very respectful of your clients because they're not going to let go of their pelvic floor if they don't feel comfortable. But really, this yogi squat should be in a position like this. You're trying to tuck the pelvis under and keep the sternum up.
Again, this is an option. If the client cannot do this with their knees, no problem, okay? Doing a squat where you drop down kind of like an exercise squat and you're in a 90-degree angle with your knees and your femur, right? Your tibia and your femur, 90-degree angles like an exercise squat. That is technically an active pelvic floor position. As soon as you go all the way down like this yogi squat, you've now relaxed the pelvic floor. So just kind of appreciating those differences as well. It's another option depending on the client's appropriateness.
Like to hold something like this for a good 30 seconds to a minute, and then you kind of can flow in and out of it. You could do something as simple as this, and then you can fold over, and then hands go back down on the floor, and then you can lift back up. If you don't want to do that, you can go from a yogi squat, and then you can essentially rock forward into something like this, and then they could sit up, and then you could come forward, and then you could tuck the toes back, and you could flow back into this yogi squat. Please do make sure that the heels are on the floor. Make sure that their feet are turned out. A lot of people who are not used to this are going to come up like this. We want to make sure that we're all the way down on our heels, feet turned out, chest up, and you're essentially like this.
Okay, so we did inhibition of the pelvic floor. I'm just going to pull my PowerPoint back up. Okay, so we did inhibition of the pelvic floor sacrotuberous ligament using the lacrosse ball or a ball. You then are releasing the piriformis just because how that muscle blends into the sacrum. It is oftentimes a little instigator when it comes to pelvic floor balance. Again, doesn't matter what the client is presenting with, SI joint pain, labral pain, groin pain. Take this kind of broadly in its application. We did a piriformis mobilization, respect if they can get into certain positions, pelvic outlet stretch to open the base of the pelvis. Okay, this is really one of the few ways that you can quote unquote stretch the pelvic floor. The yogi squat was obviously another technique that you could do. So that was inhibit, mobilize, and then you can't just leave them there, right? We have to do the activation or the awareness, which is going to be the clock, the diaphragmatic breathing with the end range expiration, something like that, that we had just done. And then really the final step, which is the integrate, is short foot. And I will be showing that after our break on how we would kind of integrate that as well. But you would then be getting them standing up, and then we integrate them with the ground and with gravity. So that is EBFA's approach for everything, is inhibit, mobilize, activate, integrate. How you weave that in programming is based off of your skill and understanding of these various imbalances that you might see. Is this okay to do if someone has tailbone pain? This is actually what you want to do if someone has tailbone pain. Okay. Tailbone pain is often associated with imbalances in the glutes, piriformis, and posterior pelvic floor. So we are trying to get some balance back into those structures through inhibition, mobilization, and activation. So 100% you'd want to do that. Randy says, I don't have many, if any, clients who can do a yogi squat. It cannot be done on a chair. I would say that what you would want to do then is the quadruped and the weight shift back. Randy, I don't know if your clients would be able to do that as a way to release the pelvic floor, but that would be the way that I would do it. Okay. Perfect. Great. So we've done the breathing already. Perfect. So we are going to head into our break. So we're heading into our first break. Let me just see if there's any other questions. Some can't get onto the floor. Okay. Could they then do it? That's why I was saying on like a stretch table or a, on the bed, something so that they're in that position. That's a way, right? So if they could get on the bed and get into all fours, great. If not, it's okay. Then I will, when we do the posterior pelvic floor, but what you can do is you can do this modified on the wall, and I'll try, can you kind of see that I'm on the wall here? Zoom. Okay, so I'm here. Here, I'm here. Right, so now I'm kind of, do you see how I'm like leaning against the wall? So if I can't get down, that's okay. I'm here leaning, and then I'm tucking my pelvis under, and I'm shifting back this way, okay? It is a way that you can do it. Now, where it's a little bit more difficult this way is that I'm standing and I'm in gravity, and because your pelvic floor is a anti-gravity muscle, it's really difficult to get a true relaxation of that muscle. But that is a way to start to get the sacrum to be mobilized. And the sacrum has an influence on the tailbone and the pelvic outlet and the pelvis. So that's how I would start to look at that. Okay. Perfect. Great, Randy. Kim asked, my client is returning from training after 8 weeks off. She had a natural childbirth, twins. Oh my gosh, bless her. Best place to start. Okay, so the way that I would start, she tends towards an anterior tilt and a tight T-spine already. Yeah, and that's going to be even tighter because of twins and being, postnatal. So she's shifted in there anyway. What I would suggest is starting with the diaphragmatic breathing and the pelvic floor clocks. If this is her first child, it's going to be also something really new for her to be like, oh my gosh, I cannot connect to my pelvic floor or my TVA. Where I remember when I had my daughter, I was really, really mentally trying to engage, and it was like the connection was not there. So all I could do was breathe and kind of go through the clock, but I was really like using all of my mental power to get even like a 10% contraction. Shut in the eyes and visualizing. So even if she can't quite get that muscle connection, just visualizing the muscles contracting and the clock moving is creating facilitation of these muscles. So I would start to incorporate that as well. You don't have to do the pelvic outlet stretch because she is already stretched, obviously. So we're trying to do the awareness and the activation phase of it. You will maybe want to do a little bit of SMR to the piriformis and some of the other structures. And then the pelvis mobilizations that we did laying on the back, where we just did these undulations and we practiced walking, you could absolutely start doing that as well. Okay. Kim says, I don't feel I understand the clock. Okay, so when we look at the base of our pelvis, this is our pelvis, but it sits like this, right? So if you had your pubic symphysis is 12 o'clock and your tailbone is 6 o'clock. So you have to think of your clock like this, right? 12, 6, 3, 9, and it's straight down. So when I'm lying on my back, I want to see the pubic symphysis and the tailbone is 12 o'clock and 6 o'clock. And then my right ASIS and left ASIS are 3 and 9. So that's the clock that I want to see. And then I'm just going to be drawing, but I'm this way, drawing my pubic symphysis towards my tailbone, which is technically 12 to 6. Okay. And in order to do that, you have to engage your pelvic floor to draw your pubic symphysis towards your tailbone. And then to draw your 3 to 9, those are the two bookends sliding together. So that's the clock. I don't know if that helps in any way. If the clock is still confusing, then, but you're like, okay, I understand the stop the pee, stop the poo, lift both. If you connect to that one, then work with that one. And that's why I try to show two different techniques. What I do want to emphasize before we take our break is that your pelvic floor is not a front and a back that is separate. You need to have awareness of that and know how to differentiate them, but really they contract as a unit lifting up. So they lift. But if we do just anterior pelvic floor and we forget about the posterior, you forgot half of the powerful fascial connection that exists within your pelvis. So that's where we want to, can you differentiate them? But can we get them as a unit to contract and lift, contract and lift? Okay. I hope that helps, Kim. Okay, great. So let's take a break. So it's 9:25. Since this is our only break, what I'm going to do is pause for 20 minutes, actually 22 minutes on the dot. We will take a short break. Okay, it's your break. So grab a snack, grab coffee, whatever you need, do some push-ups, grab some fresh air. We will start again, quarter to the hour. I will be stopping the mute and the video, or I'll putting myself on mute, pausing the recording. All right, perfect. So we had a quick question as far as Gloria said, with the ball release to the pelvic floor, I'm guessing, is irritating nerves a concern? So yes, you always want to be really mindful because your pudendal nerve does run across through that sacrotuberous ligament, the sacrospinous ligament under it, and then the iliococcygeus. So all of those are kind of anatomically within that area. The area that is where that nerve would run. So think about, we had done spot 1, spot 2, spot 3. If someone does actually have a pudendal nerve entrapment or symptoms or irritation, you could do area 1 and area 3. Don't do area number 2 because that's where that nerve runs through. But to roll and release around nerves, we do this all the time in releases. You might not even realize it. You do always want to be very mindful of nerves though. Don't put too much pressure on them, especially if they're starting to talk to the individual who's doing the release. So just do area 1, area 3, skip area 2 in someone who might have an irritation to the pudendal nerve. Okay, good question. All righty, so welcome back from your break. We're going to continue by going forward into our anterior pubic joints. As I had said, we have just quite a bit of content to go through as we head into the last wave of this session. So now when we're looking at the pelvis, right, so we could have potentially superior imbalances that affect the pelvis. That would be the way that someone is breathing. Maybe they're breathing supradiaphragmatically versus subdiaphragmatically. Maybe they're holding their breath. And So that would be a superior influence. We can have a lateral influence. That is going to be some sort of irritation into the hip joint, a hip labrum, a loss of centration in the hip joint. It could be forward, meaning anterior pubic joint, going into groin pain, which we're going to focus on now. And then it could be going posteriorly into the tailbone, sacrum, coccydynia, SI joint, and the way that all of those structures are balanced. So we are going to shift and look forward to the anterior pubic joint. Now, before I do that, Gloria had just one last add-on question to her release, and the concern if you hit the pudendal nerve is what would be a sign of talking? Is it tingling? Is it numbness? Is it pain? Typically it's pain. Sometimes you could get what's called a Tinel sign. So Tinel sign means that when you hit a nerve, you get a kind of a radiation or fasciculation down the nerve. And again, it's not damaging in a sense. If you keep doing it, yes, it can. So you want to be mindful. An example of how you could see this in another part is if you take your hand and you just kind of, I'm taking my nails and I'm just kind of peppering across the top of my hand. If I hit a nerve precisely, it's going to shoot down my hand. Same thing. Almost like tennis elbow, and it kind of radiates, or you hit your funny bone, same thing. Right. So it's not necessarily a pain, but they might be like, ooh, that just zinged down. Okay. All right. So when we're thinking about anterior pubic joint, groin pain is kind of a loose name for this. Typically, stereotypically, this is not really what it is, but stereotypically, is that people will think of this as associated with certain sports, hockey, soccer, football, where there's a higher prevalence in men, and that it's associated to an acute injury where they're doing like a slap shot, or they're kind of sliding out, the goalie's trying to block a shot, and they do kind of like the splits really quick, and then they pull their groin from that acute movement. But really what it is in the reality of muscle imbalances is that it's actually going to be quite even between men and women. That it is more of a chronic etiology versus an acute, and that it's not just associated in certain sports like hockey, football, soccer, and unfortunately it is oftentimes a diagnosis of exclusion. Now, when someone has pain in the front of their pelvis, in their groin, you want to be thinking, oh, is it the hip labrum? Now, why hip labrum tear presents in the center of the groin is that is where your hip joint sits, right? That's where your femoral head sits in the socket, is smack in the middle of your groin. So in the anterior groin. Could it be an adductor longus strain? So of all the adductors, the adductor longus is the most commonly strained or spastic muscle, the muscle that has a lot of muscle imbalances in it because of anatomy that we'll go over soon. Is there osteitis pubis, which just means pain on the pubic bone or inflammation of the pubic bone just outside? We'll go into that briefly. Stress fracture, you always want to think of that. Pubic symphysis dysfunction, so something out of the alignment of the pubic symphysis. Athletic pubalgia, this is a big one that we'll go into. And then coxus sultans. Coxus sultans is a snapping hip. And that is going to be more of a symptom than a diagnosis in itself. So when we start looking at the anterior pubic joint, the anatomy, we can start to appreciate all of the different structures here. So if we look here, the transverse abdominals, your TVA, do you see how that blends into your internal oblique? And the aponeurosis means a fascial sheath. So it's not really like a tendon per se. It's going to be flatter, thinner. We have a gastroc aponeurosis, which is kind of the fascia that comes down and covers over your soleus. We have the same thing from your TVA blending in myofascially with your internal oblique fascial extension to form a conjoint tendon here. So this is a conjoint tendon loosely using it because it's still aponeurosis. And then you're going to get your external obliques that blend into that as well. And then that blends into your rectus abdominis, and you actually have a rectus abdominis aponeurosis as well. And then your adductor longus comes in and blends into that aponeurosis. So really what it means is that there's a lot of very thin, interconnected fascial structures in the front of your pelvis as it goes into the pubic symphysis area. Now, this conjoint tendon, this is formed by your internal obliques and your transverse abdominal. So they have a deep interconnected relationship is how we want to think of it. Okay. This then becomes the pubic aponeurosis with your rectus abdominis and your external oblique. So you have these four structures blending into each other that then blends into your adductor. So on the bottom, you can see you have an abductor and an abdominal and an adductor aponeurosis. So these then blend into each other. I will show you a cadaver representation of what that looks like soon. Okay, so now we have this broad fascial attachment that's sitting in the front of our pelvis around the pubic joint, kind of around or just medial to our groin, medial superior to our groin. And it's going to have a relationship between your rectus abdominis and your adductor longus, the balance between those two muscles. Now, when we think of groin pain, again, stereotypically, what we will think, what a lot of medical doctors will think, unfortunately, is something like this, right? They'll think that, oh, you don't have that injury because you are, a 70-year-old male who runs on the weekends and loves to do marathons, a couple times a year. I don't know, something like that. But they're just like, no, you don't fit the profile. Okay. Now, this isn't just what groin pain looks like. That is, a cause, but it's actually also this. So this is really some high intense movements that are putting a lot of stress on the front of the pelvis and is often associated with improper stabilization patterns because of the level of intensity that these athletes, these are CrossFit athletes, are training at, and that they're taught to be much more about just get the rep out versus form in any way, really focused attention on sequence of stabilization and, really intense foundational programming around breath work. So this is where I see a lot of injury patterns around CrossFit athletes. Every move from what this guy is doing on the bars, bringing his toe to the bar in kind of a kipping way, is extremely globally dominant. The way that she's pushing this anodyne bike is putting a lot of pressure on the front of those hips. And then when you lock your legs like this, and then she would essentially drop her body back and do like sit-ups, right? That she's putting a lot of force on her global muscles that is creating a dominance or a inhibition of the deeper pelvic floor structures. Outside of this, though, this is also what an anterior pubic joint stress can look like chronically, right? So someone who's a cyclist, very anterior hip dominant, running, very hip flexor dominant as well. And if we do not maintain proper pelvic floor balance or pelvic balance in these repetitive movements, you can start to get chronic compensation that stresses the structures and then lead to groin pain. Same. You could add a third one on here and say, someone who had a baby. So the woman, I can't remember who it was now, I apologize, who had a client who just had twins. So the postnatal concerns are obviously there as well. They could absolutely present with groin pain as they start to resume their activities. So all of those differentials, we want to go through those and have a deep understanding of kind of our role to screen or to factor those in so that we can build programming around it so we can just optimize the movement in our clients. Okay, so the first one that we want to go into, which is probably the most mainstream or the most common that will come to mind to be associated with groin pain, will be a hip labrum tear. Your hip labrum, which happens to be a cartilaginous ring around your hip joint, deepens the socket and creates a layer of stability for the hip joint itself. Now, if you start to lose what's called centration and your femoral head shifts, so it's shifting forward, it's shifting up, it's pushing around that cartilaginous ring, we can start to put chronic pressure, stress onto the labrum, and then it can tear. Okay, so that association of anterior superior shifting to stress the labrum, leading to a tear, is very common. This will typically present as deep discomfort in the front of the hip joint, which will be the groin itself. Sometimes people will feel like it catches and like there's something kind of caught in the hip joint. That depends on how the labrum tore, and if it tore and kind of folded back in and it's kind of tucked in there, that's a little bit more difficult to navigate because of the position of the tear and the tissue after the tear. And what we often will see is that when people do repeated hip extension and external rotation, you push that femoral head forward. So joint centration, the concept of joint centration, is deeply associated with hip labrum stress. You can see here, this is the labrum deepening the socket. And when you lose centration, it will actually shift forward, and you can see the image of what that looks like. So here's a tear in the hip labrum. Okay, now when that femoral head shifts, it shifts forward and up. So anterior superior shift to the femoral head stresses and tears the anterior superior aspect of the hip labrum. So majority of hip labrum tears are going to be found in that anatomical orientation of the hip labrum. Now, there are two common imbalances that are associated with this. When your TFL engages before your pelvic floor, the TFL can pull the femoral head forward. Okay, so think of cyclists, runners, those CrossFit athletes, really anything that is globally dominant, and you're not thinking about hello, pelvic floor awareness, right? Connection to the breath. You're just driving and moving your limbs through that resistance. That TFL can start to pull that labrum forward, and like I said, you can tear it. Another common muscle imbalance that is associated with loss of hip joint centration is if your hamstrings are dominant to your glutes. So you have a synergistic dominance of the hamstrings. Your hamstrings can actually push the femoral head forward. So regardless of a dominant TFL, dominant hamstrings, glute inhibition, remember your glutes are only as strong as your core is stable, right? And your glutes are only as strong as your feet are stable. So of course we have to tie this back to our feet, right? So that's where we want to start thinking of greater impacts of some of these imbalances we might see. Okay, now generally, this is what I've referenced briefly about local and global stabilizers. We have our local, we have our global. You can look at the names on the column, right? Okay, we've got our TV, pelvic floor, diaphragm, deep rotators, psoas. Okay, the posterior psoas connects to the pelvic floor posteriorly, right? And then your global stabilizers, oblique, spinalis, glute med, psoas major, anterior. Okay, now the order at which these muscles contract is really the most important thing. So we want our local stabilizers to engage before our global stabilizers. Local then global, local then global. If we lose that coordination, we start to get a shift or a compensation in the movement around that joint. Okay, so let's look briefly at how we stabilize our hip joint into the pelvis. And this should start to make a little bit more sense because we went through the pelvic floor muscles already. So you've got your deep hip joint that is stabilized by your deep hip rotators, your local stabilizers. These deep stabilizers act like the rotator cuff of your shoulder. The rotator cuff of your shoulder contracts as a unit to draw in and suction the humeral head into the socket. Similarly, in your hip joint, your deep rotators draw in and contract as a unit to centrate your femur in the socket. Okay, now myofascially, these deep rotators are blending into the pelvic floor, right? Myofascially, these deep rotators are different than the piriformis. Your piriformis is a global muscle. We're talking about local stabilizers right now. Okay, went into that. Your deep rotators, specifically obturator internis, is blending into your pelvic floor, specifically the posterior pelvic floor, the levator ani, your iliococcygeus, blending in. Okay, and then your pelvic floor blends superiorly into the diaphragm, right? So we have a lateral and a superior. You got your anterior into the TVA, you got your posterior into the deep glutes. Your diaphragm, coming off of your diaphragm, is going to be this beautiful muscle, which is your psoas, going down, crossing in front of your hip joint, So directly behind this psoas belly is going to be your femoral head. This is your hip joint. Okay, so when we get tension drawing the femoral head, blending into the pelvic floor, into the diaphragm, the psoas, and then boom, that psoas acts like a wall, so the femoral head cannot shift forward. That is the cascade of stability that we need, that we want, that we create programming around. Okay, once all of that is stabilized, then you can start to get into your global muscles. Then you can drive power into your hips. Okay, if you do it before, you're going to start to stress and shift some of these joints. You might drive and push that femoral head forward. You might throw too much stress into the adductors, causing an adductor spasm. Okay, so everything that we've been speaking about. Now, your feet are part of your core stabilization pathway, and we'll go into how we do that. And asks, is psoas a local stabilizer? Yes, the posterior fibers of your psoas are a local stabilizer, the posterior. Okay, and if you want to think of it, you could think posterior pelvic floor is really important, posterior psoas is really important. Maybe that posterior helps you to kind of connect that association. Okay, now your feet are part of that cascade, which we'll go into when we do the integrate. Okay, so this is what I had referenced earlier as far as the true step of how EBFA Global looks at correctives. We inhibit, we mobilize, we activate, we integrate. What are we inhibiting? Whatever's dominant, right? Get into the global muscle, the TFL, the QL, the piriformis, right? In the foot. Maybe it's the extrinsic muscles, the muscles of your calf, your posterior tibialis, that are dominating the small muscles of the foot. Is your TFL dominating the piriformis, or is your TFL dominating the pelvic floor and the posterior psoas? Is the adductor longus inhibiting and dominating the psoas and the pelvic floor? Oftentimes, yes, right? So we have to inhibit whatever is globally dominant. Once you inhibit, you kind of quiet it down. Once everything is quiet, we then mobilize and try to recenter things. This is where we did mobilization of the pelvic outlet. We did mobilization of the piriformis. Now we're going to do mobilization of the femoral head in the socket. So we're going to recenter the hip joint because we're talking about the hip labrum right now. Once you mobilize, you can't just leave the body there. You have to then bring stability into that new range of motion. That stability is driven through the local stabilizers, pelvic floor, diaphragm, deep rotators. That was the clock that we did. That is the diaphragmatic breathing. That is the end range expiration that we did. And then finally, you got to integrate it with the ground and gravity. This is where we lock it in, standing up. You got to be in gravity, so stand up. You got the pressure on the system, and you are doing short foot to core activation. I would say do it barefoot on an Aboso mat, add in something to the hands if you need, use kinesiology tape if you need, use compression apparel if you need. Okay, so we are trying to connect to the body and gravity in our integration. Okay, I am going to go to the video that is demonstrating these 4 steps. You can absolutely, I encourage you to join me as I go through these 4 steps. As I pull up that video, if you have any questions, just type those in, and then we'll jump on into those videos now. And just remember, I'm giving everyone access to these videos. Okay. And these are also some that these sit on the EBFA YouTube channel. So that means that you can actually share them with your clients. And I will send these to a lot of my patients and have it be the way that they walk through it, because especially with virtual training is it's hard to get hands-on. You obviously see that it's hard to do kind of like a Zoom demonstration to them. So having videos from someone who's filming it from a different camera can oftentimes be very helpful. So please share these videos if you want with your clients, for them to be able to follow them and understand the techniques.
The hip labrum reset is going to be your corrective exercise strategy for any client who has lost hip joint centration or who may have a torn hip labrum. This series is going to include an inhibition, followed by a mobilization, then an activation, and finally wrapping up with an integration. So we inhibit, mobilize, activate, and integrate. The duration that you want to do each of these 4 segments is for 5 minutes. Now, because we're doing a neuro reset, this may require your clients to do this several times a day. That means that if they cannot commit to giving you 20 minutes several times a day, then you may reduce the time to 3 minutes for each of these sessions, or totaling 12 minutes. If they could give you 12 minutes 2 to 3 times a day of doing this corrective exercise neuro reset, that is where they're going to notice a difference. We're going to get started with this reset with the inhibition. The first step in this corrective exercise series is going to be the inhibition. We're going to be inhibiting the global muscles, specifically targeting the TFL, adductors, and piriformis. Now, you could use a variety of release techniques or tools such as the lacrosse ball, a foam roller, or even a stick or rod. I'm going to use a lacrosse ball. Let's get started with the TFL. So your TFL, which is positioned on the upper outer quadrant of your hip, you're going to start on your stomach with the ball or roller underneath the TFL muscle. Now, as I place the ball underneath that muscle, I'm going to bring my left leg forward to control my body weight. I'm on my elbows to, again, I control how much pressure I want to put on the ball and on the muscle. Now, I'm not on the bone, I'm on the muscle. I'm not going to roll back and forth. I'm going to sit in this position. And then if I wanted to bend my knee, I could do that to release and get a little bit more into the ball and into the muscle. And then after being in this position for about 30 seconds, I'm going to move my body forward, which lowers the ball a little bit more into the muscle. Again, I'm in this position, nice and relaxed. And then if I want to bend the knee, I could do so, or I could just hang out here, nice, relaxed inhale and exhale. Now, to transition into your adductor, we want to be focusing on your adductor longus. So we're going to take the ball or the roller. I'm going to rotate slightly, and then I'm going to put the ball right underneath where the adductor longus is going to come towards its insertion. Again, I'm in a position like this, where I'm in control of the pressure on the ball or the roller, and then I'm just going to hang out here. Again, if this is not giving you enough of a release, you can look towards a release tool that has a little bit more height to it, such as a roller. After 30 seconds or so in this position, I'm going to move my body a little bit to the left, which rolls the ball a little bit more to the right. And then I'm hanging out here. I'm a little bit closer towards its insertion. So I feel definitely a lot more of the release. After a minute, minute and a half on this muscle, I'm going to go to the final muscle, which is going to be the piriformis. I'm going to grab the lacrosse ball, bring myself up into a seated position. And now I'm going to place the ball kind of where the pocket of your jeans would be. So I'm going to start kind of near my sits bones. I'm going to place the ball directly underneath my pelvis, and then I'm going to roll towards my right side. I'm staying in a position like this. I could even roll even more so, and then that's definitely on the piriformis. You are in control. Now, to get a little bit more release, you're going to drop the knee to the side, and you're going to bring it back up. So this is a way to gradually increase the amount of pressure on the ball and the release to the muscle. After about 30 seconds, I'm going to roll my body to the left so I get a little bit more towards the right of the muscle. And then the same thing, knocking the knee to the side for that release. Again, we're targeting the global muscles. You don't have to do all three of these muscles. You don't have to do 1.5 minutes on each, but you have approximately 3 minutes to 5 minutes on the inhibition section. If you feel that the client's TFL is really the dominant muscle here, spend a majority of time on that muscle, and then you could move to the adductors if you would like. Once you do that inhibition, you're going to go immediately into the mobilization step. The second part of our corrective exercise reset is going to be the mobilization. We want to make sure that we are doing this immediately after the inhibition step. What you need for this is some sort of belt, strap, monster band, or resistance band. You're going to have the client be in a quadruped position. Now I'm going to be showing you 3 different ways to mobilize or recentrate the hip joints. In that quadruped position, you want to make sure that the client is staying passive. You, the trainer or coach, are doing the work while they are relaxed. Now, the specificity of where you position yourself and where the angle of the pool is very important for the effectiveness of this mobilization or recentration technique. So I'm going to be using a belt, but again, please remember that you could use that resistance band or monster band. I'm going to start by placing the band or the belt underneath the leg, and you want to have it placed very high up into the groin. Now, if you were too low onto the femur, you wouldn't get that same mobilization. Remember, we are trying to be within the joint, deep within the joint and centration. So the band is going around, and then I'm going to position myself in a 45-degree angle. Remember, the client stays relaxed, I'm doing the work. The line of pull is going to be a 45-degree angle. I'm not straight back, and I'm not directly out. So this 45-degree angle is factoring in for the femoral neck angle. I'm in this position and I'm pulling with my one hand. My opposite hand is going to be on the hips to give a little bit of a resistance. And then I'm pulling in this position. He's staying relaxed. I'm staying here for approximately 1.5 minutes. Now, if you feel like you want to increase the pull, please don't have the client move. You are just going to add more resistance to how much you're pulling. After being in this position, again, about 1.5 minutes, you're then going to go into the second position, which is going to be with the one leg forward. So he's going to lift his chest, come up into a lunge position. He's staying stacked between the rib cage and the pelvis. My position stays the same. I'm at a 45-degree angle, pulling in this direction. Again, I could counter if I would like. He relaxes, I'm doing the work, and I'm giving that traction. He should feel or may feel like there is an opening up or a distraction within the joint. It's not going to be a sudden pop and you relocated the joint. We are bringing space to the joint. That is what this mobilization technique is built around. After about 1.5 minutes in this position, we'll go into the final position, which is going to be on the back. He's going to go onto his back. He's going to bring his right knee to his chest. And then the belt, this one, the position is going to be slightly different. So this will also go towards the front of the hip. He's going to bring the knee to the chest, but this time my angle of pull is going to be straight. Remember, the first two were at a 45-degree angle. This one, I'm pulling straight towards me, and I'm actually pulling down as well. I'm talking to the client to see how they're doing. He's staying relaxed. I'm doing the work. And after about 1.5 minutes in this, you would then release and proceed into the activation series of this strategy. Now for this one, you want to ask them, which one do they feel the decompression or the release the most? Whichever it is of the three, you can favor towards that one. You don't have to do all three techniques. You might do just the first one and the third one. Or if a client likes all three, you could do all three release techniques. Remember, you have approximately 3 minutes to 5 minutes for this step. The next step in our corrective exercise series is going to be the activation. This should be done immediately after the mobilization, as we need to lock in the inhibition and that mobilization. The activation is going to be to the local muscles. For the local muscle activation, we're going to be targeting the diaphragm, the pelvic floor, and then the deep rotators.
So just in case if you're following and you're like, we already did the pelvic floor and diaphragm, hold tight because we actually add on another muscle to it. So you would do pelvic floor diaphragm first, and then through the pelvic floor contraction, we're actually going to engage our deep rotators. So please hold tight. This will be a little bit different.
For the deep rotator activation, if you don't get it right away, I encourage you not to get frustrated. These are very small muscles, and it takes a lot of mind-muscle connection to get into those muscle contractions. Let's get started with the diaphragm and the pelvic floor, and then we'll wrap up with the deep hip rotators. Let's get onto our back. And you're going to be in a position so that your feet are flat, your knees are bent, and that you can easily create a stacked rib cage and pelvis. So we're stacking the rib cage and the pelvis. I'm going to place my hands just inside my ASIS. I'm going to shut my eyes because if you remember, we want to visualize the face of the clock. So just immediately start to see the 12, 6, 3, and 9. We're going to inhale through our nose, and I want you to feel the belly rise. Now, as you exhale and as the belly starts to come in, start to draw 6 o'clock to 12 o'clock. Keep the breath moving the entire time. And then good, release, inhale, feel the belly rise. Again, start to exhale, 6, 12, hold. Now start to draw 3, 9. Keep the breath moving, feel the tension. And then good, release, inhale through the nose, feel the belly rise. Again, start to exhale, 6, 12, 3, 9. Keep exhaling, feel the tension. And then good, release, inhale, feel the belly rise. I want you to bring your legs straight. We're going to proceed into our deep hip rotators. Now for this one, what we're going to be doing, if you remember, your deep hip rotators draw in. They have a drawing in or a suction effect to your hip joint. So we're going to be in the same position. If you needed to put a foam roller or a bolster underneath your knees, you absolutely could. But we're going to be in this position. We're going to do the clock as we did before, but this time after you engage the pelvic floor, I want you to visualize your deep hip joint. We'll start with the right side, and I want you to feel like you are drawing in that hip joint. Some of my students have said before that if you make a fist and then you relax that fist. So you can think of the hip joint like a fist. You could think of it like a hand and it's grabbing and it's drawing it in. One of those visualizations may help you. And now the sensation that you want to feel is tension-based. You should not feel your quads engage and you should not feel your glutes engage. This is a deep local muscle activation. If you feel like the global muscles are engaging, we need to relax those, relax the glutes so that we get the proper activation. Your hands could be in the same place, and let's get started. Your eyes are shut. See the clock, see the hip joint. We're going to do 2 times on each side during this exercise. When you're ready, start to inhale, feel the belly rise. And then start to exhale, 6, 12. 3, 9. Keep exhaling. I want you to start to see your right hip. As you keep exhaling, reach in and draw and tighten in that hip joint. And then good, release. Let it go. Inhale, feel the belly rise. Again, start to exhale, 6, 12. 3, 9. Stay on the right side. I want you to see the hip. Reach out and draw in. Tighten that right hip. Beautiful. Stay there. If you feel your quads contract or your glutes contract, you want to relax. and then release, let it go, inhale. 2 times on the left side. When you're ready, start to exhale, 6, 12, 3, 9. See your left hip. Start to draw in and tighten that left hip joint. And then good, release, let it go, inhale, feel the belly rise. And then again, start to exhale, 6, 12, 3, 9. See your left hip, start to draw in and tighten that left hip. Do not squeeze the glutes. And then good, release, let it go, inhale. Beautiful. Now that is us getting into the diaphragm, pelvic floor, in deep rotators. All of the local stabilizers that are going to help to lock it in. After you're doing that activation, do not forget that you have to finally seal it in with the ground and gravity. The final step of this corrective exercise series is going to be locking it in with the ground and gravity. That means that we have to be standing up in our bare feet, and we're going to be connecting the feet to the pelvic floor and our breath. So I want you to start with your feet shoulder width apart, knees are slightly bent, stack the rib cage and pelvis, and then let's put our hands either just inside the ASIS, or if you like to be in a position like this for breath awareness, you could do that as well. I'm going to place my hands just inside the ASIS. Now I want you to start by inhaling through your nose and feel the belly rise. And then as you exhale, we're going back to the clock. Start to exhale, 6, 12. Keep exhaling, 3, 9. Keep holding, keep exhaling. Feel how the pelvic floor feels now that you're in gravity. And then good, release. Let it go, inhale, feel the belly rise. And then start to exhale, 6, 12, 3, 9. Keep exhaling. Now, as you're exhaling, start to connect your toes to the ground. Keep exhaling, and then good, release. Let it go, inhale, feel the belly rise. One more time, start to exhale, 6, 12, 3, and 9. Start to push the toes down into the floor. Your breath is moving the entire time. Keep exhaling, 7, 8, 9, 10, and release, inhale, feel the belly rise. Beautiful. You're going to bring it onto your right side. Knees are slightly bent, and you're essentially progressing for 3 to 5 minutes into single leg foot to core sequencing. So we could carry this exact same cueing on the single leg. Knee is slightly bent, opposite leg goes up, you're pushing your toes into the ground, and you have your 6, 12, 3, 9. And then we're just going to hang there for a moment. Keep the breath relaxed while keeping 6, 12, 3, 9 toes are down. Yes, we start to get more challenging with the balance, but we're trying to maintain foot core activation throughout that single leg stance. Once we do the one side, we're of course going to switch to the other side. Knees slightly bent, spread the toes, engage the core, 6, 12, 3, 9, toes down, opposite leg comes up, and then we're staying here for approximately 20, 30 seconds, just feeling what it feels like to keep foot to core engagement in an upright position. The breath is staying relaxed. From here, you can progress into a variety of other single leg exercises. We do have a video coming up, which is going to show you a 15-minute series.
Okay, perfect. Are there any questions on the hip labrum reset and when and where you would apply that? But again, you're just following that same protocol: inhibition, mobilization, activation, and integration. Understand, the goals of each of those phases. Know that it's not exactly the same inhibition. That's, again, your skill set to understand that. The activation is always the local stabilizers. The integration is always with ground and gravity and sensory stimulation. So like I said, I would do it on an Eboso mat with compression and tape and something in the hand and things like that. That's going to be your general protocol that you are going to follow. Okay, hip labrum. Your second cause of anterior pubic pain or a anterior pelvis imbalance is osteitis pubis. This means pain on your pubic bone. This is going to be more of a symptom than an actual diagnosis. Now, this is where you would have point tenderness right here. So if you can see my arrow, it's going to be right on that bump. You can even feel that on yourself. Hopefully you don't have pain there, but you'll say, oh, okay. And that's where your adductor is coming into your pubic joint, and then directly above is going to be the rectus abdominis, and then all of that aponeurosis kind of crossing that we'll find there. But pain on palpation on that bone, inflammation on the bone, if you keep pulling tendons, like your adductor tendon keeps pulling on the bone, you create an inflammatory reaction. You can get inflammation in the fascia, like a periostitis, or you can actually get bone marrow edema, which just means the bone itself is inflamed. Okay, now again, it's a symptom, it's a cause. Look at some of the bigger imbalances that are there, such as hip labrum, athletic pubalgia, things like that. Or it could just be not even a diagnosis, but more just a local global imbalance, and that they're not stabilizing their pelvic floor fast enough to set the base through which the adductor contracts against, and then you get too much tension. Like it could be that, and that's not necessarily a diagnosis if you think of it in a traditional way. Coxosultans is another symptom, not a diagnosis. It means snapping hip. There are two types of snapping hip. One is internal, one is external. The internal snapping hip is more prevalent, and this is where when you go from extension to flexion to extension, your hip snaps. And what the snapping is the psoas tendon is rolling over a tubercle on the femur. And when it rolls over it, you get that snap. Okay, so the extension to flexion, actually, if you do flexion, abduction, and you come in and you adduct and flex, you will get it as even more. Common exercise that you would see this on is if you're on your back and you're doing bicycle exercises, and those bicycle exercises, every time you bring your leg down straight to do that part of the bicycle, you get a snap in the groin. Or some of the Pilates moves that you're doing, like hundreds and things like that, that you will get a snap every time you bring your hip down. This is telling you that something is out of alignment as far as it relates to the femur in the hip joint. Have they lost centration? The femur shifted forward, and then we get the snap of the psoas. That is one. Is it that they have a delay in the pelvic floor stabilization and the psoas itself, and then that causes this? So that's where we want to explore a little bit more as far as that cause. Now, your psoas, because the psoas is rolling over that tubercle, we want to be a little bit aware of the psoas anatomy. Now, your psoas, we know it comes off of the diaphragm going down in front of your hip joint, and then it inserts back into the pelvic floor. It acts like a wall in front of the hip joint, blocking the femoral head so that it cannot shift forward. Okay. Now, if you're assessing the psoas, we want to, we can test it by doing a flexion external rotation, and then they're pushing into your hand, and then that would trigger a symptom within the psoas, because you can absolutely have psoas tendinitis. You can have, overactivation of the psoas. This is where people will probably go back and forth and say, no, you don't need to stretch a psoas. There's no such thing as a tight psoas. Typically, I try to approach psoas symptoms through SMR, trigger point release of the posterior pelvic floor, the piriformis, the adductors, the TFL, to then find balance, and they do diaphragmatic breathing and a pelvic floor clock. And that's how I like to find balance in the psoas. All right, now we're stepping forward into our fourth and final consideration to the anterior pelvis and stress to the anterior pubic joint. This is where we come into athletic pubalgia or a sports hernia. This is going to be a tear of the pubic or the abdominal aponeurosis. It can also be a tear into the adductor aponeurosis as well. So it is a fascial tear, a break in your fascial continuity, which is important to understand. Anytime you get a break in your fascial continuity, your fascial tissue, you've just disrupted the sensory system, the neuromuscular control, and the timing of stabilization of these structures. So it is like a little monkey wrench that keeps throwing off the timing of stabilization for these clients. Okay, this can then cause coxasultans. This can then cause osteitis pubis. This can then cause increased stress to the hip labrum and centration, and then lead to a subsequent hip labrum tear. So they all become interconnected. Okay. So when you look at the athletic pubalgia structures, these are the same ones, right? Transverse abdominals blending into the internal obliques, which becomes the conjoint tendon, blending into the external oblique and the rectus abdominis, all of those. Okay. Now, if we look for a moment at athletic pubalgia, hip labrum tear, osteitis pubis, coxasultans, psoas syndrome, all of these different considerations that we looked at, the constant theme that we are coming across is that they all have to do with coordination of stabilization. That is really the name of the game here. Okay. And that we are trying to emphasize the local global coordination. The local global coordination. So specifically in this injury, what we're looking at is some of these fascial attachments and where we find an imbalance of tissue stress. Okay. Now, a lot of people will think of their obliques running into their adductors. For those that are familiar with various fascial lines, right? A lot of people will say, oh yes, your right obliques blend into and influence your left adductors, and then vice versa. Your left obliques blend into your adductors. So we kind of get this cross body pattern that we activate when we walk, almost like the glutes blending into the opposite lat, right? We do, that exists. But there's also another one that we have here. This is going to be same side. So not contralateral, but unilateral, same side. Rectus abdominis on the right side has a blending in and influence into the right adductor longus. And then left side, left rectus abdominis blends into the left adductor longus. Okay, both of those. And it's kind of like a tug of war that your pelvis is trying to stay up in a neutral position through the rectus abdominis, and then gravity is trying to push it forward into an anterior tilt. The path of least resistance for your pelvis sagittally is to go forward, right? So if we were just like, and we relax, your pelvis is going to fall forward. And the reason for that is that your center of gravity is actually in front of your body. It's not even in your body, it's in front of your body. So it's going to pull that pelvis forward into an anterior tilt as the path of least resistance against gravity. So there has to be a constant force pulling the pelvis out of that gravity pull, and that is your rectus abdominis. But then on the bottom, you have these really strong adductor longus that are just pulling you down into that path of least resistance or that anterior tilt. Okay, that tug of war is what's stressing all of this beautiful fascial anatomy. So this is what we were going over earlier, how I was kind of emphasizing that it's fascial, it's interconnected, it's complex, right? That we have our conjoint tendon, you have your abdominal aponeurosis, you have your adductor aponeurosis, all of these are fascially blending into each other. So when you get a tear here, the tear is kind of right where this is a clamp, where the clamp is touching the tissue right here. That's usually where you'll start to see the athletic pubalgia or the sports hernia tear in the aponeurosis will be about there. Okay. And then this is where the adductors are coming on. Someone's going to palpate right here, and that's where that osteitis pubis would be, but it's because there's actually a tear right here. Okay. So now resisting shear around that pubic joint is really, really important. And this is built around having sufficient stability and the timing of that stability in your local stabilizers, specifically TVA and internal obliques. And what influences TVA and internal obliques is your pelvic floor. Pelvic floor will upregulate the activation and the timing of the TVA and the internal obliques. So when someone starts to get a delay in the pelvic floor or a disconnect to the pelvic floor, they get a subsequent delay in the TVA or a weakness in the TVA, which then gives an advantage to the adductors, and then boom, they can start to get osteitis pubis, adductor spasms, groin pain, athletic pubalgia, etc. Okay, so these are just a few research studies that say, hey, yes, people who have growing pain have delayed TVA activation, right? I could put a similar research study that says people with low back pain have delayed multifidi engagement. Same thing, right? So stress to the front, we got delayed muscle stabilization, same to the backside. The muscles that they're referencing, whether it's multifidi or TVA, are local stabilizers. Okay, so that's where the name of the game has to be: inhibit, mobilize, activate, integrate. Local global coordination, local global sequencing, stabilization. We need to think about the timing of these muscles in all of our clients. Okay, so as we take that look, we want to be thinking about, okay, what are we doing for these clients to create balance? It has to start with education. They have to understand the differences in these muscles. If they don't understand and you're just having them do things and they're just like, okay, I engage my pelvic floor, or I start my sessions with breathing and pelvic floor awareness exercises because you tell me to do so, right? But they don't understand. Like, that's not good. We want them to understand why they're doing that, right? So that if they happen to ever train without you, they can continue that practice. And we don't like to just be told things blindly. We want to understand why. Understanding and educating increases compliancy so much more. Okay, improving our warm-ups, especially in specific programs like CrossFit and competitive sports that don't really think about the timing in the same level. You can prevent many, many injuries by building that as part of the foundation. We're focusing on motor control, or really, I would say, coordination. So the understanding and relationship between local and global. Okay, and then we are, of course, being progressive. We're coordinated. We are driving this from the ground up with the foot activation, foot to core sequencing, short foot, and your breath patterns. So breath and feet, boom, meet in the middle with your pelvic floor balance. Okay, we've gone through this already, so I'm not going to show you that, but I just want to see if first there are any questions about the anterior pubic joint, injuries or imbalances that we see in the anterior pubic joint, whether it's from the hip labrum to the psoas, to coxosultans, to osteitis pubis, to then athletic pubalgia. I just want to take a moment and see if there are any questions. Okay, we'll let it process. And then we are going to go into our final topic, which is the posterior pelvic floor. And then from the posterior pelvic floor, I'm going to discuss how you can incorporate foot to core into some programming. So it's not just you standing there doing short foot, exhaling, engaging your core, but there's actual exercises that you want to incorporate that into. Okay. Anne says, let me think, I'm processing it. Okay, so I'm gonna give you a moment to process that. Is there a way that you can physically tell if the femur is forward in a hip labrum tear? Okay, so the way that you can tell if someone has a loss of hip joint centration is outside of them saying, oh, I have pain and snapping and catching and pinching in my hip joint, right? Is that they will have decreased range of motion. So when we lose centration, we shift off of the center of cartilage that is on both of the joint surfaces. So this is the acetabulum and this is your femoral head, right? You want it to be centered so you get maximum range of motion. If we deviate forward or up, I'm now no longer in my center of range of motion. So typically what it will present with is that someone will lose range of motion. How you could see that is you could say, okay, I'm doing a hip assessment. And if I'm like, wow, that is great internal, external rotation. You got some good range of motion on your left side. You go to the right side and you're like, whoop, what happened there, right? How come you don't have any range of motion? That's typically how it presents. Also, if someone has, remember, external rotation can push the femoral head forward. So extreme external rotation pushes the femoral head forward. So if someone stands externally rotated like a duck, you essentially, see if I can show it with my shoulders. So if someone rotates like this, they're essentially doing this. So as I rotate my hip externally, my femoral head shifts forward. Okay, so I lose centration. So if I have a longer leg, let's say my right leg is longer than my left. So my compensation to shorten my right side is to turn my foot out. And when I turn my foot out, or I externally rotate at the hip to shorten the leg, I do that and I start to boop, push that head forward. Now I lose range of motion. I'm in an externally rotated position. I'm asymmetrical all the way into my pelvis. So now I locked the triplanar motion of the pelvis, and right now we're kind of where we are. Okay, so I hope that makes sense of how you want to take what you learn in this session, or really every session you do with me, every session this weekend if you're joining with me, and you have to be little detectives, and you put all of that in your memory Rolodex. And then when you are seeing a client, you want to kind of zoom in and look at something, but then also zoom back out, right? But don't stay too far out. You still want to come back and zoom in. So let's say that the issue is, you know, decrease hip external rotation on one side, or internal rotation, right? Lack of range of motion on the right hip. Okay, internally, what does that mean? Okay, or locally, what does that mean? And then let me zoom out and be like, oh, I see them walking. One leg is externally rotated. Okay, that movement pattern globally. Why are they doing that? Okay, stay global. Understand the compensations, longer leg. Okay, let me zoom in and assess to see if they have a longer leg. Okay, if they do, right, zoom back out. Look at them. Okay, what's the greater impact of that? Right? What is happening when they take steps and walk? Oh, because one leg is longer, one stride length is longer than the other. So the rotation in the T-spine is not symmetrical one way versus the other way because they have an asymmetrical stride length. Okay, let me zoom back in. How do I increase and find balance here? Right? So that's how I want you to be kind of navigating all of your clients. It really is detective work. I love it. I love just kind of understanding the mystery of everyone's body, because everyone presents slightly different. Everyone has a slightly different history, and you always want to factor that in. Okay. Great. Another pause for any other questions? Okay. We will continue with the posterior pelvic floor. We are on the home stretch. I felt so pressured that I had to talk fast on the last one. I do apologize, because then I blew through it way faster than I thought I would. So shame on me. I will slow down now. Okay, so now we're going into the posterior pelvis. And this is one that we had already gone through the mobilization of the posterior pelvic floor, the piriformis mobilization, the pelvic outlet stretches. I showed you that already. That was applicable to posterior pelvic pain. So just apply that. But again, it's not only for posterior pelvic pain. And when we say posterior pelvis, this could be tailbone, this could be the SI joint, this could be the low back. I will be focusing a little bit more on the tailbone, so the coccyx, so just appreciate that. But of course, remember, we can go even broader and go into the SI joint and into the lower back. So now when we're thinking about tailbone pain, coccydynia, this is in an individual and a client. This is going to be triggered by sitting, obviously, because you are now kind of on your tailbone, or you shouldn't be on it, but you are putting pressure around those structures. It is more common in women for the reason that we went over in the beginning, that the passive orientation of the male sacrum is more tucked under than the females. The females is more vertical. So if we do not tuck and move that pelvis, or the sacrum and the tailbone, fast enough or sufficiently when we sit down, then you can put pressure on it. Also, if you sit not necessarily in a posterior tilt, but you sit in a anterior tilt, you could actually be sitting on your tailbone, and you don't want to be straight down on your tailbone. Okay, you can sublux or dislocate. You can fracture your tailbone. My sister-in-law fractured her tailbone during childbirth because of how the baby came out. So you definitely can fracture it in different experiences. And it's typically visualized because it's a joint that moves. If you do a live X-ray, which you don't want to do a lot of these because so much radiation is released, whew, hacha-macha, but it's called fluoroscopy. And if you essentially hit the X-ray machine and instead of doing a quick snapshot, you leave it on, so it's just actively engaging, you can actually move, and then you can see the way that the joints move. Sometimes in my podiatry office, if I want to look at the way that the joint is moving under X-ray, I'll do them, but lots of radiation, so you don't want to have a lot of that done. Okay, so when we move from a standing to a seated position, you can see that it's tucking under. So your tailbone is scooping under, tucking the tail, almost like an animal tucks their tail under, right? We're tucking our tailbone under, okay? And this is where we can just appreciate one more time the orientation of the male sacrum and the coccyx versus the female. And the purpose of that is childbirth, right? So we need to be able to tuck that pelvis. Now, when it comes to muscle imbalances that are around the tailbone or the coccyx and the sacrum, we want to understand the anatomy that attaches here. Okay, so you have your sacrum, and then coming down on the bottom is going to be your coccyx or your tailbone. On the front of your coccyx is going to be your levator ani. Okay, so we're back to those muscles that we went over earlier, the super important ones. Okay, and really you're going to see that it's all of them, but it is a broad aspect of the iliococcygeus that is attaching to the anterior tailbone. Posteriorly on the tailbone, you have your glute max. So really direct attachments, that's kind of it, right? You have posterior pelvic floor, glutes, and then they're playing tug of war on your tailbone. Now, some other considerations for that is that don't just think of the attachments in the tailbone as front and back or anterior, posterior, but also think of it as kind of like 4 quadrants. So your tailbone, you could have tightness in the right levator ani, and it's going to pull the tailbone forward and to the right, versus you could have a overactivation in the left glute, and then it's going to pull the tailbone posteriorly and left. Okay, so think of it quadrants. It's not just going forward and back, but it can be pulled side to side, diagonally. And if there's an imbalance in any of those muscles in any of those quadrants, you can then start to create pain and symptoms. Now, also anything that attaches to the sacrum is going to influence the tailbone, because the sacrum and the tailbone are attached and they have direct influences. So how your sacrum moves will influence tailbone. Which is why sacrum stretches are really important. That's why I had said that if you're doing that pelvic outlet stretch, or if someone can't get on the floor and do a quadruped, go against a wall and tuck the tailbone and then guide their sacrum into a posterior tilt, guide some mobilization into the sacrum so that it can move, so you can also free the tailbone. So the structures that are attached to the sacrum are going to be your adductors, your bicep femoris, coccygeus, so part of your levator ani, erector spinae, external obliques, glute max, piriformis, blah, blah. So there's a lot of structures. Now, the one that is oftentimes a instigator in this is going to be your piriformis. Okay, so piriformis, you do want to make sure that we got inhibition, mobilization of that structure. You also do want to make sure, because that is a global muscle, that if the piriformis is causing a locked sacrum, which is stressing the tailbone, and they're presenting with coccydynia, think in the back of the mind that if they have a dominant piriformis and they have a history of sciatica, let's say, or a history of piriformis syndrome, that coccydynia can have a direct correlation to that history of sciatica. Let's say you can actually have sciatica and coccydynia at the same time. And then the association or the driver of that is it's coming from the piriformis, and the piriformis is locking up that sacrum, which is then stressing the tailbone. And there's a lot of research supporting that addressing piriformis, what it does to coccydynia, positive association. You got coccydynia, look at the piriformis. Okay. All right, so let's just look briefly at the anatomy. Here, of course, we got our psoas, right, coming in front. You can, if you follow the belly of that muscle, right, down, 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 you can see my arrow. You can see how directly there, that's the hip joint. So it's acting like a wall so that that femoral head cannot go forward, right? So we want to appreciate that. If we look over here, this is your obturator internus, bloop, 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 to here, blending into your iliococcygeus. So this is blending. And then here's your iliococcygeus attaching to the front of your tailbone. Piriformis, that guy's attaching to your sacrum. Okay, so we want to make sure here, coccygeus, which is part of your posterior pelvic floor as well, attaches to the sacrum here, right? So we always want to find balance around the sacrum. We always want to find balance around the coccyx. Okay, this is a different orientation here, just appreciating. We didn't necessarily reference the tailbone and appreciate that when we looked at this orientation before, but you got your glutes here on the posterior aspect. You got here, this is your levator ani on the anterior aspect. Here, this is your anococcygeus ligaments. You want to make sure that that has mobility in it. That's blending into your superficial layer of your pelvic floor. Beautiful. Sacrotuberous ligament is tucking in here as well. I guess we're just appreciating the anatomy. And then a final one, this image moves, which always freaks me out, but so I don't know why it's moving. Here that we can appreciate the iliococcygeus here, blending into your obturator internus, just a different orientation. Piriformis, and then your glute max. I think it does it on purpose because it makes me want to talk faster. Okay, so here we go. You got a client who has tailbone pain, coccydynia. And you know what? It's something that I find that if you don't ask them, they don't mention it, right? So people typically, unless that is their primary chief complaint, are not going to come see you and say, help me with my tailbone pain, right? One, they might also not understand the tailbone. A lot of clients and patients, lay people just don't understand the anatomy of the tailbone. They know it's there and that you can fall and break it, but that's about it. So you want to say that if they have, hip pain or groin pain, ask them some of these other questions, right? Do they have pain in the pelvic floor? Do they have incontinence? Do they have pain when they have sex? Do they have pain in their tailbone? So ask them these triggering questions because it will help you understand. It'll paint your picture a little bit more. So when you're presenting with someone with posterior pelvic pain, is that you want to think about restricted sacral movements that can stress these structures. So is that caused by the piriformis? I don't know, right? Is it caused by the posterior pelvic floor? Okay. Is it caused by a lack of lordosis and that they're stuck in an anterior tilt? Maybe. Okay. Is it actually stuck posteriorly? It can be stuck posteriorly as well. And I see that in a lot of clients who do a lot of these bar classes. In New York, there was a method that was called Lottie Burke, if anyone is familiar with it. And there would be what we would joke, and it would be Lottie Burke butt. And a Lottie Burke butt would be this extremely posteriorly tilted sacrum. But as soon as they did that, they locked their pelvis, and you can't take long strides and everything that we spoke about in the beginning of this session. And it causes pain, stress, right? Is it caused by pelvic floor spasms? Typically, those spasms are in the posterior pelvic floor. Levator ani syndrome is what it would be called. So levator ani syndrome is specifically spasticity and adhesions in the posterior pelvic floor. Okay, is it associated with pregnancy? You could, if a baby is facing the wrong direction, they can be pushing into these structures. Their forehead could be pushing into the tailbone, causing pain that way. Are they obese? And then the obesity is causing a shift in the pelvis because a center or a change in the center of their mass, an inhibition of some of the deep stabilizers. Do they have piriformis syndrome and sciatica? Definitely have been emphasizing that one a bunch. SI joint pain, absolutely. That causes this inability to nutate and counter nutate. So we've got to be able to do that. Do they have a pudendal nerve entrapment that is causing perineum pain? So it'll be in the base of their pelvic floor, the perineum. Oftentimes that's where that will present because that's what that nerve runs into. Or do they have sacrotuberous ligament contractures as well? You could also have psoas contractures and hypertonicity of the psoas as well. That could be associated here. So all of these you want to be factoring in when you have someone with posterior pelvic pain, i.e. coccydynia. All right, so now just so that we can appreciate the sacrotuberous ligament. So your sacrotuberous ligament, this is, we had shown briefly what it is, but it's arising from the back of the sacrum. So it's going to influence sacral movements. If this ligament is too tight, has adhesions, it's gonna kind of lock down the sacrum, and then it blends into the coccyx. So we have this direct attachment between the sacrum and the tailbone, okay? And then is blending into the iliac crest or the iliac spine. So broad attachment, okay? And the sacrotuberous ligament, it's going to contribute to the strength of the pelvis. It controls nutation and counter nutation. So the rotation. However, we don't want to completely inhibit rotation of the pelvis or nutation of the pelvis, but you need control because you don't want to exaggerate that either. And then it provides attachment for your glute max and your bicep femoris, which we know your sacrotuberous ligament is what your bicep femoris attaches to. And then when it pulls down, it closes and stabilizes the SI joint. This is where we see our sacrotuberous ligament across here, right? So we can appreciate here, this is the issue tuberosity. That's what your hamstring is blending into. And then it's going to pull down, and then that's going to tighten your SI joint. Okay. Slightly different perspective here to appreciate it. This is where, if you remember from the palpation that we did in the ball release, that we went from here to here to here, right? So we're kind of working along here, which is right across that ligament. The pudendal nerve that someone had asked about runs like this. So if someone does have a pudendal nerve entrapment, release spot 1, spot 3, do not release spot 2. Always do bilateral. So do the right side, do the left side. Okay. I had shown a video of these releases. So the sacrotuberous ligament release, this is similar to the inhibit, mobilize, activate, integrate. So just remember that exact video that I had shown you. Okay. In this position with the lacrosse ball, we had the video. After you do that, inhibit the piriformis, stretch the piriformis. This is a way. You don't have to do it this way. Understand the client's anatomy, mobility, stability, strength to be able to get down on the floor, such as this. Now the pelvic outlet stretch, this was one of them where you shift back, you can go on the quadruped. And then this is this here standing on the wall. This is the one that I was saying you could do if the client can't get down onto the floor. If the client can't get into like a child pose position, no problem, right? We do it like this. Okay. And this is my husband. He's not pushing into, so he's not compressing my sacrum. His line of pressure is actually kind of like that. So he's trying to guide my sacrum to tuck under like this. Okay. These are also really good for pregnant women because of all of the changes in the expansion and the loosening and the chaos that is happening when you are pregnant and giving birth, is that a lot of this can just kind of de-stress some of those tissues and make sure that the sacrum isn't stuck as your pelvis is opening up. So you could do it in this same position. I'm in a child pose and he's guiding my pelvis to tuck under. I could just be in a half kneeling or in a kneeling position, a quadruped, and then guiding the pelvis to tuck. I could be against the wall like this, all of these. Okay. And then of course, relax the pelvic floor as you're doing it. Okay. So that is going to be the inhibition and the mobilization. I would follow that. Again, this is in someone who has coccydynia. So coccydynia, we inhibit, we mobilize, know that, great. The activation is saying hello to our diaphragm and our pelvic floor. When you say hello, that is more of an awareness exercise. That is not a maximum contraction. That is, you know, a 10 out of 10, because if someone has a pudendal nerve entrapment or has their tailbone being pulled forward because of levator ani syndrome, we are trying to bring mobility and relaxation to the area, but then you can't leave them hanging there. You got to reactivate the stabilizers. So that is just a hello clock. Inhale, exhale, nice and easy. Think 10 to 20% max contraction. You're just saying hello to these tissues. And then you stand up and you get into gravity and you stack your rib cage and your pelvis, and you could say hello to your feet and your pelvic floor and your diaphragm, and then that's it. Boom. That's your set. That's how you're locking it in. Okay. So it's not anything that is super, super aggressive. Now, what I do want to go through, and it'll be the last video that I show, but it'll be important because I want you to see how you can bring these exercises then to additional exercises. So I'm going to take you through a series of foot to core exercises. So let's say it is the hip labrum stress. They've lost centration, you recentered the joint, you inhibited, you mobilized, you activated, now you've integrated, but you need to eventually do more movement besides just that short foot pelvic floor exhalation. That's how you connect it. It's the cherry on the top, but then to actually apply it to exercises and functional movement, that's the part that I want to go into. Okay, because that's the part that takes everything that we spoke about and it moves it to the next level. You can't do corrective exercises for the rest of your life, right? You eventually have to add on, make them more challenging, make them more functional. Okay, so I'm going to pull that up, and I will add a brief comment saying that what I go over this weekend, if you're taking any of my sessions, hopefully you are, on Saturday, I'm doing one on body perception and the reducing falls through body perception and your body awareness. So our ability to sense ourselves. Take that, if you're attending that, amazing. Take that information that you learn on Saturday with me and apply it to these exercises I'm doing right now with you. It's a video, so please join me. Please join me as I go through these exercises. Or of course, you can take notes and things like that. You could vicariously work out with me. I don't judge, okay? So then when you're doing these exercises that I'm doing right now, let's modify them. Let's apply them to our older client. I'm barefoot. I'm on the Naboso mat. I'm actually on Naboso flooring in this video, but I'm thinking about how do I bring sensory stimulation to my feet. Okay, so that
foot to core sequencing.
Okay, so I'm barefoot. I'm on the Naboso mat. Make it a little brighter. Okay, so that I'm bringing that sensation. Maybe during these exercises, I want to hold the neural ball. So I get stimulation in my hand. Maybe I have two of them and I'm holding them here. So I have that and I'm building sensory stimulation through my tactile nerves. If I want to get even more body awareness, which I'll go into on Saturday, maybe I want to wear compression apparel when I'm doing this. I'm going to wear a sleeve or maybe compression leggings, elbow, right? It helps people to feel their body. Maybe I want to do this with wrist weights on. You could absolutely do that, or ankle weights. It helps your client connect to themselves. These exercises can be modified. So if I do a broad side lunge, no problem. We could just do a side step, shift back. I don't have to go into a full single leg stance. I could do a side step to a foot together narrow stance like I'm standing in right now. Doesn't have to be full lunge to a single leg, but I want you to see and experience. So please try to do these exercises with me if you can. I want you to experience where the placement of the foot to core contraction is. Every exercise I take you through is going to weave in short foot, exhale, pelvic floor lift, boom, okay? That's the secret sauce of this final integration, and maybe I need to come up with another word, but the functional application. Once you integrate, what's next? It's obviously heightening it and applying it to actual functional movement. So please join me for these exercises. And then after we go through this video and you join me for these exercises, I will go over any questions that you have as we wrap up this pelvic balance course.
some of the most effective ways to strengthen the pelvic floor. It's also how we lock in our corrective exercise strategies with gravity and the ground. So I'm going to take you through a 15-minute series of exercises that you could use as the integration part of the corrective exercise strategy, or it's a great way to do more advanced, more functional pelvic floor exercises. For this, we're of course going to be doing short foot, which is the action of pushing your feet down into the ground. Every exercise I take you through, I want you to really feel how every time you push your toes down, that your pelvic floor lifts. That's the opposition that we're trying to feel. Toes down, pelvic floor up, and then whatever exercise that we're doing, let's say if we were doing a squat and coming out of it, I want you to feel that you are lifting with your pelvic floor. You lift with the pelvic floor, which is lifting with the exhalation. And then of course, again, the toes go down through each of these exercises. So let's get started in a single leg position. I'm going to take you through single leg exercises because those always have higher glute/core engagement. You could always modify any of these exercises as a kickstand, or of course could try to be bilateral in them as well. So we're going to start in a single leg stance. I'm going to be on my one leg. I'm going to start with a slight bend in my knee. Feel the foot to core connection. And let's just do little small flexions. Yes, there's single leg squats, but I just want you to feel how a little flexion down and an extension up and how that feels within the body and the pelvic floor. Now to make it a little bit more, since I'm talking, I'm going to kickstand my leg. I want you to inhale as you go down, push your toes into the floor, lift your levator ani, and then exhale, lift through your pelvic floor and the TVA, and then release both. Little bend in the knee. Toes go down, pelvic floor, TVA, and your levator ani go up. Slowly go down, toes go down harder, lift through the TVA, release. Little flexion, feel the connection. Inhale as you go down, toes go down, lift. Exhale, lift through the TVA, and then release. Let's do the same thing on the other side, low repetitions. Slight bend in the knee. Again, the sake of me cueing, I'm going to be in a kickstand. You could be in a full single leg stance if you would like. Slight bend in the knee, start with the connection. Inhale as you go down, drive the toes down. Exhale, lift through the core, release. Little tension, hold. Inhale to go down, drive, tension goes higher, tension higher, release. One more, little connection. Inhale, drive the toes down, feel it in the posterior pelvic floor. Exhale, lift and release. Great job. Let's get into a single leg deadlift position. I'm going to rotate to the side just for the sake of the camera. Your right leg is forward, your left leg is back. Start to feel that connection between the toes and the core. Your knee is bent. Beautiful. I'm going to have my arms in a reciprocal pattern. I'm here. You, of course, could go lower if you would like. And start to keep foot core connection. Feel the levator ani engaging. Put energy in that back leg. Extend. Imagine someone's pulling that leg behind you. You're engaging your foot, your calf, your quad, your glute. Length through that entire back leg. Stay there. Hold their connection. Feel your TVA. Imagine someone is pulling your sternum forward and there's a length through your entire body. And then release. Great job. Same thing on the other side. Same position. Your left leg goes forward, your right leg is back. We'll do the reciprocal arm if you would like. Feel the foot core connection. Shift the body forward, hips are square. Start to put energy in that back leg. You're pushing your toes into the floor. You're pulling the sternum forward, stay there. Try to engage every inch of that body in a nice, controlled, fascial tension way. 4, 3, 2, and release. Great job. We're gonna bring our right leg forward into a lunge. Lunge position so that we are here. I'm going to bring my reciprocal arm forward, tucking the pelvis into this position. I want you to feel the ground underneath your feet. Just connect, feel, get the toes connecting to the ground. Now feel the ground, and I want you to lift the heel up. And then you're going to lower the heel down. Every time you lift that heel up, I want you to engage your core. So lift and then release. Again, lift and then release. Exhale, and then release. Let's do one more hold. Lift, hold, Slowly lower down, your arm is forward, you're going to bring it in. So as you pull in, your toes are pushing down, and then we inhale back, chest up. Heel down, toes down, shh. Inhale back, chest up. Heel down, lean the body, toes go down, shh, and then back. Let's do one more. Heel down, lean the body, push your toes down, shh, and release. Great job. Same thing on the other side. So your other leg goes forward, find that lunge position. Perfect. You're in that reciprocal arm position. Start with just the heel lift. Now, what we're starting to connect is every time you lift the heel, I want your TVA to engage. Keep doing it while I'm talking, please. So as you do it, TVA, release. TVA, release. If it's not just engaging, I want you to engage it. So we're in this position. Feel the toes, feel the ground, right? Toes are down, shh, and down. Good. Shh. Perfect. Let's do one more. Shh. And then lower down, reciprocal arm. Push your toes down. Exhale brings it in. Inhale, bring it back, chest up. Heel down, pitch the body forward, toes down, shh, and back. Perfect. Two more. Heel down, lean the body, shh, and back. One more. Heel down, lean the body. Exhale comes forward, and then we bring it back to the start position. Great job. So we've done single legs. We've done some sagittal plane. We did a single leg deadlift. We did that reverse lunge with the heel raise. Now we're going to start going into a couple other planes. So we're going to go into the frontal plane. This is going to be either a weight shift or a side lunge. I'm going to start on my left leg, and I'm going to come out to the side position here, and then I'm going to bring it to here. Now, of course, we're focused on the pelvic floor. So every time I step out, this actually relaxes and lengthens my pelvic floor. Every time I bring my leg back in, I'm actually engaging my pelvic floor. So this is the release. This is, of course, the inhale. And then this is the exhale, or a kickstand, you might choose. When you come back to this single leg position, I want toes down, pelvic floor up. And of course, exhale. So you have to coordinate all those steps. So we inhale, and then shh. Inhale, side lunge, shh. Inhale, side lunge, shh. Inhale, side lunge, shh. Okay, do one more after that. Boom, perfect. One more, and shh. Great, let's do the other side. Again, anything that's giving a little bit of a relaxation and activation to the pelvic floor is what we want, because when we move, this is how your pelvic floor contracts, right? It contracts, relax. It's like a sinusoidal rhythm, or it's rhythmic. Now I'm on my right side. Shift out, and then, right? Inhale, inhale, right? If the arms are confusing, don't do them. Out. Right? Is your foot connecting as well? Toes down. Toes down. Do two more. Toes down. One more. Great job. Great. Okay? So that's a building foot to core, pelvic floor in the frontal plane. Now, if we want to get into something that is transverse plane, we're going to add a little bit of a rotation. So we're going to do a rotational lunge. So I'm going to have you start. I'm going to be on my left leg. And I want you to imagine that you're on the face of a clock. So my left leg is at 12 o'clock. And then my right leg is going to step out, which would be the equivalent of my 5 o'clock. I'm going to sit down into a lunge here. As I sit back, I'm going to lift my front toes. Try not to keep them down. You want to lift them. And then I'm going to shift back to here. Now, as I shift back to here, toes down, core in, lift. Okay, so this is your inhale, exhale, inhale, shh, inhale, shh, inhale, shh. Do two more, use your toes, shh, one more, and shh. Great, same thing on the other side. Okay, again, lower repetitions. We do just a little like spice it up, okay? So I'm now on this position. I have my right leg at 12 o'clock. I'm going to my equivalent of 7 o'clock. So I'm bringing my leg out, 7 o'clock, and then I'm going to sit down into the lunge, lifting my front foot, place the foot back down, and then back to this position. Inhale, 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 2 more, 1 more, and great job. Perfect. So now we're actually going to start getting into some jumps, because this is really important, especially if you're working with athletes and the athletes are trying to get back to sport or back to the game. Now, when we jump, it's us building this relationship of decelerating from the ground up with foot to core, and then of course accelerating from the ground with foot to core. So let's start. I'm going to bring my right leg forward, my left leg back, and I'm in a reciprocal arm pattern here. So I'm going to start by just doing this, okay? But before we do it, I want you to push the toes down, engage your core. Back, back, back. Now my right leg, foot's core, short foot, leg is like a tree trunk. Exhale back, exhale back, exhale back. Now, as I do this, I feel a lot going on here. Okay, if you were to compare that to not doing the foot to core and you kept your foot relaxed, totally relax your foot. This is like a fun experiment. Relax your foot. And now try the same thing. Do you get the same engagement? I hope you're shouting no from home, right? You don't, because your feet are such an important part of your core. Let's do the same thing on the other side, just to prime it. Foot engagement, core engagement, make this like a tree trunk. Exhale back. Right? All I'm doing is priming the system, okay? Now, once we have those reciprocal arms, we're going to go into our first hop. Not a jump, a hop. This is what you're going to do. You're going to go up, back, little hop, 1, 2. Do you see that? Land 1, 2. 1, 2. You're going to roll through your foot, okay? Up, back, little hop, 1, 2. Up, back, little hop, 1, 2. Perfect. Up, back, little hop, 1, 2. Just getting into it. Let's try the other side, both sides. If you want to do more repetitions, push pause, and I want you to do more repetitions. Same thing, right? Here. Whew. Perfect. Up, back, little hop, 1, 2. Up, back, little hop. All I'm doing is getting used to landing from the ground up. This is the first step. Great. Now, once you have that, what you're going to start to do is you could focus on jumping higher, which means you're getting the acceleration part of it, right? If we're going to push off, I need you to really use your entire foot. For the sake of this video series, we're not going to do that. I'm going to take you through the next step that would really emphasize the foot to core punch in this exercise. So what you're going to do is you're going to do up, back, little hop here. And I want you to stick it. We're now in a single leg squat. So your toes go down, core goes in, exhale as the punch when you stick it and you land between each jump. Are you ready? Okay, so here we go. Same thing. So we go up, back, little hop. Big exhale, big exhale. Use your breath. Up, back, little hop. Again. Up, back, little hop. As my foot hits the ground, boom, it's contracting. Up, back, little hop. Awesome. One more, then we switch sides. Up, back, little hop. Perfect. Let's do the other side as we wrap up. Same thing. Quick exhale, quick core, quick feet. Okay, here we go. Up, back, little hop. Again. Up, back, hop. Here we go. Keep going. Keep going. Keep going. Really emphasize the punch. 2 more. Up, back, hop. 1 more. Up, back, hop. Perfect. Whew. That gets you warmed up, definitely. Okay. So I hope that you take this series of foot to core exercises as a way that you can really challenge the pelvic floor by using from the ground up techniques. Remember, what creates stability in relation to the ground and gravity is how your feet connect to your core, specifically your pelvic floor. This is driven through contraction of the toes into the ground, a lift to the pelvic floor, and your exhale. This could be used as a corrective exercise strategy. It's a great warm-up, and it's what I use to prep the nervous system for all of my patients and clients.
Excellent, great. So again, these were just exercises that are demonstrating how you can apply it to more exercises. Course modify, a great one that I love to do for older clients is, instead of a jump, obviously that could be quite intense for them, is if you step off of something. So if you're on a step, like a little step, like an aerobic step, they stand on it and they step off of it onto the floor, and you teach them 1, 2, right? But as soon as their foot touches, boom, they short foot, right? Or as soon as their foot touches, and exhale. I like to do force exhalation. It just kind of helps to drive it a little bit more. It's also auditory, so it kind of forces it. So that's a way, right? That's mimicking foot awareness, foot stabilization, foot to core stabilization when they step off a curb, right? So very functional. Stepping up. Instead, I could put my foot on the step and step up. And as I step, I'm going to engage my foot, short foot, and exhale, step onto the step. Step to the side of the step, step on. So you're doing different stepping patterns, super functional, right? In addition to maybe just little baby flexions, right? You can squat, a quarter squat. It doesn't have to be a full one. Like I said, a side step, a step up, a step down, right? So just see how you can incorporate that. Always thinking about the foot to core and the breath and the intent behind that, and that the timing of that. One last example is it could be something that's not even lower body exercise. They're doing a bicep curl, right? But every time they do the bicep curl, push the toes into the floor, exhale and engage the core when they lift the weights, and then bring them right back down. Okay, so that application applies to everything. All right. So as we start to wrap up and kind of bring this summary together, we're thinking about these advanced concepts in pelvic balance. Is always, always, always consider the timing of stabilization of these muscles. Local versus global coordination. Breath is a driver to stabilization. Your feet are a driver to stabilization. Consider the role of foot to core in all of it. Yes, that is EBFA's theme, really around everything. And then breathing and diaphragm considerations. And then consider the role of emotion, anxiety, the autonomic nervous system on the pelvic floor, on the way that we breathe. We have a course through EBFA called Interoception Performance Specialist. This is looking at interoceptors, how we breathe influences our state of well-being. I'm actually going to go into that on Saturday as well, my Saturday session, which will look at interoceptors and breathing patterns. Am I safe? That whole concept. So that will be in that session, and that applies to this as well. A lot of people will put stress in their pelvic floor and then have a hard time releasing it or finding rhythm with their diaphragm because they're just contracted to hold on any of their, survival mechanisms. So something to think about. So ask your questions as we wrap up. So Kim has a question as far as her 67-year-old client with very stiff spine, short gait, stiff arms, minimum swing, has a foot neuroma connection. So I don't think I know your question. How would you start to apply this in them is my guess. So I'll just allow Kim or anyone else to type in their questions while I wait for Kim. Does the neuroma have to do with the stiff posture? Most likely what is happening is that the foot and ankle complex is very stiff, which is forcing her onto the ball of her foot. It's plantar flexing her, right? Because her ankle is so stiff. So we shift forward to the ball of our foot. And when we shift forward to the ball of the foot, we put more pressure on where these neuromas would sit. So I would say, is the neuroma causing all the stiffness, or is the stiffness causing the neuroma? The stiffness is causing a triggering of an already existing neuroma. That's how I would connect it. So mobilize the feet, mobilize the ankle, mobilize the pelvis, mobilize the T-spine as good as you can. If she has arthritis, obviously it's going to be very difficult to bring optimal mobility, but can we bring a little bit more balance? That would be your goal. Okay. Some of our clients will not take their shoes off. Is there a way to get the same benefits? Yes, you can do short foot in your shoes, but honestly, that's where I would go to the Naboso insoles. And that's really where we apply them and why we designed them for individuals, why our insoles are so powerful, is that it brings the level of barefoot stimulation into the shoes to help the client stay connected in their feet, because the feet are such a driver to the deep core pelvic floor stabilization. So if they can't go barefoot, totally get it. My session tomorrow is about the aging foot and how the foot tells a story. So that's where I would go into things like that, but definitely use the Naboso insoles in that case. Osteoporosis, there's not a connection between the osteoporosis and the neuroma. Anne has a question about incontinence and overactive bladder with a 92-year-old client. She has been recommended to do tibial nerve stimulation. Is bladder related to anterior or posterior pelvic floor control? How is tibial nerve stimulation related? My guess, so this would be anterior. Bladders is anterior pelvic floor, but my guess is, and if you could tell me maybe how they're telling her to stimulate her anterior, or how they're asking her to stimulate her tibial nerve. Your tibial nerve innervates your foot, the bottom of the foot, the intrinsic muscles, your posterior tibialis, which are all your short foot exercises. So I don't know if they're trying to do intrinsic and foot contractions to connect to the core in the exact same way that we do short foot. That might actually be the way that they're kind of trying to drive it. I would just be curious on how they're telling her to stimulate her tibial nerve. Any other questions? Tibial nerve stimulation, so like E-stim. Yeah, so the E-stim of the tibial nerve through kind of like an electrical muscular stimulation, things like that. I mean, it could. It's really I wouldn't put my full weight on it, meaning like I wouldn't be like, yeah, this is guaranteed to work. Could it, because of the connection between the foot and the pelvic floor? Yes, but the connection between the foot and the pelvic floor is a little bit more posterior. So I would still have them doing short foot, Naboso, things like that, diaphragmatic breathing. I would still be doing that with that client, even though she's doing this TENS unit or an EMS unit at the doctor's office. That could make sense. Okay. Gloria asked a question, is a lack of joint centration a factor of hip bursitis? Yes, sometimes it can be. Sometimes it can be. Oftentimes the hip bursitis, if you get any sort of movement of the femur, you shift where the bursas and the trochanters and the tubercles all relate to each other, and you could shift it and then, you know, get a little bit more of the bursitis. Oftentimes hip bursitis is because of overactive and kind of clamped in lateral muscles, so the glutes and the stabilizers into that lateral line. So it can be related. I would still address pelvic floor inhibition, pelvic outlet stretches, diaphragm, pelvic floor, foot to core, kind of everything that we spoke about for someone with hip bursitis, because it is interconnected in some way. Yes. Okay. Rex asks, foot to core, when the foot hits, will you enumerate which muscles activate in sequence overview? Yes. So you want to have foot contacting the ground, you get an intrinsic activation. Intrinsic are the small muscles in the foot. That leads to a posterior tibialis or a extrinsic muscle engagement, which blends into your adductors and your pelvic floor. And then from the pelvic floor, you go lateral to the deep rotators, anterior to the TBA, posterior to the glutes, superior to your diaphragm, and then it zips down to your psoas. So you kind of get this cascade of intrinsic, extrinsic, pelvic floor, diaphragm, deep hip, psoas, deep glutes. Now your global muscles contract. So maybe you get your glute max, you get your obliques, you get your rectus abdominis, then you get your adductors, and then those engage. But the foot to core, that's the ones that I had just referenced, which is your deep front fascial line. Okay. Anne asks, do abdominal scars from C-sections, appendectomy, hip replacement procedures affect pelvic floor muscles? Absolutely. Scars can inhibit muscles. You do want to release scars. So what you would do is in your inhibition phase, let's say if they have a scar, in the step one, which is the eye, when you're doing the global muscle inhibition, you then want to do a scar tissue release. So you're just rubbing the scar, maybe doing some cross friction if you're using a Graston tool, whatever it is, but you do want to release the scar and then you mobilize, activate, integrate. Okay, but you definitely will see that they will inhibit local muscles. They inhibit locals. So think of scars kind of like global dominances, is that they do that. Question on, would it be possible to integrate short foot sequencing in a group without the intro steps? Meaning that you don't inhibit, mobilize, activate, you just go to short foot. Yes, you absolutely could do that. If you are doing that, then I would just try to connect it to the breath. That if you're having them connect to their feet, you can have people not doing any inhibition, not even doing any breath work, and just have them stand with their feet shoulder width apart and then just rock forward. So I'm doing like a forward rock. I'm leaning. It's hard to tell, but I'm stiff as a board and I'm leaning my body forward. As soon as I did that, my digits contracted and essentially did the short foot contraction. The forward lean is a great way to say hello to the feet, to the intrinsics, right? Hello feet, and then stay centered and try to get that same contraction. And then you're doing short foot, right? And then do bring that into squats, right? You know, theoretically, my series, I could do 5 forward leans, I don't know, right? And then I'm standing with my feet shoulder width, slight bend to the knee, and then I'm just going to push my toes down, release. Push my toes down, release. Let's say I do that 5 times. And then I'm going to go into squat, push my toes down, exhale, bring it up, relax my feet. Inhale, go down, push toes down, exhale, lift, and then release my feet. Inhale. And I did 5 squats that way, right? And then I could go into other exercises. So yes, absolutely. You can definitely do that. Okay. It is a corrective, but it's also an awesome exercise. It's a great way to train the feet. Okay. Really, really good questions. You guys are going to get the recording from FAI. I don't have access to the recording, but what I do have access to is the PowerPoint. So I will just be sending you another email that has a link to it, just so you have it. I know there were a couple people that maybe did not get it, so I will send that to you. And then I will send you another link to a Dropbox folder that has accessory videos. So all of the videos that I've shown you in here are going to be in that Dropbox folder so that you can share them with your clients. There's also some that are linked on YouTube. So I'll make sure that that is in the email as well, so that you can share those with your clients. And if they want to reference back on those, if you say, hey, when you do this, watch this video, it goes through the technique, and then make sure you do that every day. You could absolutely do that. Okay. So please do look for that email. I hope that I see you guys on my sessions. Tomorrow I'm doing Every Foot Tells a Story. And then on Saturday, I'm doing this body awareness and fall reduction. I really, really appreciate everyone's time. I hope that you enjoyed the course. I hope that you enjoyed the conference, and I hope that you are doing well. Thank you all so much. Have a great day. Take care. Bye. Thank you guys all so much.